and sisters, aloha. Thank you. I don't know if you remember, but last conference I told you aloha is one of my favorite words. It means hello, it means goodbye, but my favorite is that it means the ha, the breath of life, even eternal life. And I love speaking in front of you, wonderful sisters and brothers who are keepers and holders of eternal life. You are so powerful, and we are so grateful for you to be here. So I'm going to wait as everyone comes on in. Come and have a seat. We are really excited to announce our keynote speaker. His name is Dr. Ben Danielson. He works with Children's Hospital and also with the Odessa Brown as the clinical director. I've seen and interacted with him on different levels, and one of my most favorite is that he took care of one of the babies that I got to catch. And this family is so sweet and so loving. And when we have to turn them over to higher care, it's something that is so hard to watch. But it's so amazing when we turn them into the hands of Dr. Danielson and to see how much care and love he takes care of our people. And so one thing that I asked Dr. Danielson, what would he like all of you to know, is that he looks to you to keep him accountable on a different level. So come to him with all your questions. Just kidding. But with those special people that you need to transfer to him, I know you're in safe hands. And so we're so grateful to have him here. So we'll turn the remainder or an hour to him, and then we'll oh yeah. Shh. Thank you. All right. So now we'll turn the time over to you.
Thank you very, very much for inviting me to be a part of this day. I wanted to participate in more of it, but I couldn't get here before this time. But it's such a pleasure to be here, and I see so many faces that are familiar to me, so many people that I admire, and makes me feel especially humble to actually be holding a microphone and talking in front of you. I do talks on different topics many, many times, and I'm the world's worst public speaker, and so I struggle through that. So I figured, I hurt my knee on Sunday playing basketball, and so I figured if I walk around a little bit and you see me limp, there'll be this sort of empathy thing coming out, and you really feel like what I was saying was powerful and impactful. The second thing I wanted to say is preparing for talks like this are always hard, but this felt especially difficult for me for lots of reasons. One is that I'm often in the position of trying to talk to, say, medical students or even physician colleagues about issues around institutional racism or cultural contextual issues. And I kind of know the very, very low ground floor from which they are experiencing these topics. And speaking with a group of people whose lives and professions and hearts are at a much higher evolved level for these kinds of topics kind of makes it an extra challenge for me. So to let myself off the hook, I will still talk about this in some of the ways that I would have talked to, say, a medical student or someone who's a little bit less enlightened, and you can just see your enlightenment in the places that you've gone beyond that. How does that sound? So I wanted to start with just telling on myself. I can't say it any better than myself. So I want you to know how badly my brain works and partly why it works so poorly sometimes. When I first started medical school at the University of Washington some 187 years ago, it was interesting because on day one of school, one of the first diseases we learned about was sickle cell disease. And it was interesting to learn about that. The first 2 years of medical school, are just like for you, are just very basic science-oriented, learning biochemistry and anatomy and systems and things like that. And instructors choose sickle cell disease because it is one of those diseases that shows you everything that a first-year medical student would want to know about. It teaches you about how a single amino acid substitution due to one single change in your DNA can lead to this disease. So when you're learning about DNA and genetics and amino acids, it's a perfect thing. It teaches you Mendelian inheritance and how genes are passed on and how diseases in carrier states occur. So if you're learning about that stuff in your first days of training, it's perfect. It teaches you about how proteins are developed and designed to have a certain shape, and when you don't have the right amino acids or basic building blocks, then the shape changes and the function ends up changing. So you learn all of these really, really interesting things that are very related to the stuff you're trying to cram into your head in medical school with sickle cell disease. And so I made this huge mistake and thought that after the first couple of years of medical school that I actually knew about sickle cell disease. And I didn't. I didn't know a thing about sickle cell disease. And it wasn't until maybe my second day of working at the Odessa Brown Children's Clinic that I actually started learning about sickle cell disease. And I had to sort of turn off the brain that was thinking about the Mendelian genetics and the amino acid substitutions and the constructs that were in those micro levels and really start to figure out how to stop and listen to families teach me about sickle cell disease, teach me about the impacts on the whole family, teach me about the importance of doing everything you can to allow a child to have days that are filled of school and fun and joy and not ERs and hospitals and pain medications. To teach about how much institutionalized racism enters into the lives of someone who experiences sickle cell disease. Teaching me about how a 14-year-old boy walking into an ER with sickle cell saying that he's in pain relies on this ER provider to look at him and decide whether or not he trusts that boy that may be a different skin color, that may not act the same as other kids do in pain because a sickle cell person lives in pain so much of the time. There's no blood test that tells you how much pain somebody should be in when you have sickle cell disease. There's no imaging study that tells you that it's located in your lower back or in your right arm. All you get to do is trust that person who says that they're in pain. And that is a moment of intense, intense opportunity for bias and stereotyping to fill that room, fill that ER, and change that child's life. We learn about things and we learn processes and we get information. And then at least for my training, it's almost like we have to retrain our brains to do the actual part of caring and giving that are so important. And that comes essentially from relearning how to listen. So I had to go on this journey of relearning how to listen. And so I'm subjecting you guys to listening to this journey of me going on through this journey of learning how to listen through listening. I want to tell you another learning situation, and again to prove just how lame I am about learning things. So two quick stories from a family that I get to work with in the clinic that are Somali, I guess now Somali American. And one was this mom with two boys who are pre-teenagers came to me for a checkup last week, and she said, by the way, you're not going to see these boys for a couple of years. I'm taking them back to Africa to school, to Kenya for school. And by now I'd been working in the clinic for a while, and I thought I was pretty savvy and hip and cool to cultural dynamics and other things. And I said, stop right there. I know exactly what's going on here. I understand totally. I know that for a brown-skinned young male entering pre-adolescence and adolescence, the streets in America can become a very dangerous place. It can be very scary as a parent to see your son out there and either targeted or labeled or treated in a poor way because of the color of their skin or because of their age and their gender. And so I get it. You are sending your kid to Kenya to go to school to avoid the hard streets of the United States. I jumped into this whole dialogue in my head and was explaining to her something before I'd actually finished listening to her. So she was really kind and patient, and she heard me out. And then she said, I'm sorry, but no, that's not it at all. It's because the schools in Kenya are much, much better than the schools in the United States. Which is another really sad truth, right? And a really interesting recognition that someone who has seen the world more than others might be able to say with great authority. I was jumping into a conversation and I was having this dialogue in my head and not listening to what this mom was wanting to tell me and share with me. Her sister also had a young baby that I was seeing, and she was planning to have her next child soon, and we were talking about her having her child. And again, I was jumping into my internal dialogue of trying to be very on top of what was going on in my community. And so we were talking about the rates for Somali women of not seeking early prenatal care. And we were talking about what was going on with that for their community. And I was asking these questions around, how can we make it more comfortable for you to go seek care in the medical system earlier on? And the piece in my head that I wasn't saying was because my assumption is that that is going to make for a safer pregnancy. And so we talked about these different strategies and these different issues. And after a while, she stopped talking back. She just sort of listened and smiled and nodded her head. And it took me a minute to understand that she was waiting to educate me about something. And so finally I stopped, and she said, thank you very much for all this information. It's very interesting. But that's not why we don't go for early prenatal care. The reason is because you, in America, pathologize pregnancy. You turn pregnancy into a disease, and it's evidenced by this 1 out of every 3 pregnancies turning into a C-section that you have. We have no interest in risking a C-section every 3rd time we go into the healthcare system. And your system needs to learn and change before you will see me as a endorser of that approach. And it's interesting to me to just think about those moments and be embarrassed by them, and also think about how I don't listen, how I don't always hear what is there in the offering for me, how I don't always take the messages that are coming to me that I'm supposed to reflect on and become someone who's able to be a better care provider, a better person, a better human being, maybe even out of that process. I think about those lessons all the time, and it makes me really want to talk with like medical students and early trainees about things, about how it is that we get to this place where we allow bias and racism to enter into our profession, because I know there is not a single medical student who goes into their work saying, I'm going to be especially biased today. So, but we live in the Northwest. And the double whammy of living in the Northwest is not only does it feel really terrible to somebody to learn about racism, it feels especially terrible to learn that they might be a component that contributes to racism. We're not especially good at looking at ourselves honestly in this community, at least in the communities I see. And so how do we talk about these issues, and how do we use them as a lens and an opportunity to figure out how to listen better, how to not jump to assumptions like I was with these moms, how to be a more forgiving and attentive and engaged part of a relationship between myself and a mother and a child. And when it comes down to it, I think one of the the greatest, luckiest things about being in healthcare for me is the opportunity to share stories. The opportunity that through those stories you get to share lives. The opportunity that through those stories about lives you get to intrude on the most touching and sentimental and personal and important pieces of people's experiences and their hopes and their dreams and their joys. And what a profound disappointment if you had that moment to sit there and share a story, to participate in life, to be a part of their experience because you're sitting there with them, and you blow it or you waste it because you stopped listening, because you made an assumption about your environment, or because your perspective was a little bit changed by your propensity to some kind of generalization, some kind of bias or stereotype. So when I talk to medical students, I tell them about the difference between bias and stereotypes and how those can lead on to prejudice. We talk about things about culture because culture is a nebulous term, and because I work with medical students who want to have everything clearly delineated in a list that is perfect so that they can answer it on the test later that week. And so when we talk about these issues around what is culture and what makes up culture, I find it very interesting to hear how different people define and appreciate culture. We talk about personal culture and the many different ways that we go through identifying people's cultures and characterizing people and categorizing people. And I invariably get a bit of a pushback from a student who will say something like, I am less biased because I don't use any of these categories and I just see everybody exactly the same. And then I say, I feel really badly for you because you see everybody exactly the same. What a horrible disability to have. to not appreciate difference, because appreciating difference is such an important piece. That's a piece of that jewel, that opportunity to share a story and know a story of somebody's that they're willing to give you. So we talk about these things, and we talk about why sometimes that information is important, because you can learn things about people's health experiences, the way the healthcare system treats them, and things like that from those characteristics too. Talk about cultural influences, because sometimes people come from places where they've not had different impacts on their cultures, like the patients that they're working with. We talk about how the ideas of migration and resettlement could really affect how you look at something institutional like healthcare, and how the issues of being part of colonization and having the social dynamic influences from establishments, from governments, from hierarchies that you used to live in really impact the way you look at social dynamics and hierarchies and organizations and institutions in this country. And you'll hear me say several times how fortunate I feel that you are for not being as much of a participant in a hierarchy and in an institution and in an organization. And I will say to you that I also hope that doesn't make you feel like you're off the hook for recognizing that you are still part of a power structure, that you are still part of an institution on some level, that you represent a different kind of structure, but one that might be recognized to somebody from a different culture as hierarchical or as organizationally constrained. Does that make sense? I make that mistake in my clinic all the time, where I think because historically we've served an African American community, and we've got, a beautiful, our waiting room is like, whenever I need to have a good day, I sit in the waiting room for about 10 minutes and I see these colors and these cultures and these languages and these kids and these energy. And man, if that doesn't make you want to be a better care provider, then you need to go work on computers somewhere or something. And it's amazing. But I make this mistake that means our staff and all of us are already very, very ensconced and very knowledgeable about culture and diversity. And it's only occasionally I see how the corners of those senses of knowledge and experience are actually pretty constrained, and how I have really, really conservative and really under-inclusive members in the clinic that I work in at the same time that they get to see so much diversity in their midst. I talk with people about these individual cultural determinants, and I talk about all this stuff because I'm trying to get them to a place to appreciate culture and not try to categorize culture quite as much. But that there are things about sense of self and space and communication and language and dress and appearance and time consciousness that really make for an important place for how they think about their healthcare, how they think about the interactions they want to have with you as a provider, how they want to consider their body and their health, and how they want you to respect their bodies and their health. These are all these things I go through, and sometimes I show really cool circular charts and other times triangular shaped ones, and sometimes they look like asteroids and things like that. We talk about these values and these norms, these ideas of group and individual dependence and conformity, partly because if we look at our healthcare system, like for me, what I see is a system that does not embrace a different view of how people think about health. I think about just our simple things like HIPAA and how that doesn't seem to allow you to share information with people for whom a culture might think are very important members of the decision-making process for a health decision. Our hospital rooms are not conducive to a huge gathering of family coming together or community members joining in a conference to talk about what's best for the healthcare decisions for this child. Our systems of gaining permission to do things are very legally and very uniformly based, and they don't support the idea that there may be lots of different people who might have very good reasons to have a right to help in the decision making for someone. The way we think we have to inform about conditions and give information is very, very focused on the society that we live in, but not in the diversity of the society that we embrace. I think about the framework of culture and how it is influenced by our worldview, and I try to tell students about this fallacy, this almost religion of science, about how technology is the answer to every single problem that could ever be thought of, is in itself a very singular view that is not shared across a lot of different cultures and a lot of different perspectives. This idea that we could, through the competition of knowledge, which is what I see in the way research works, which is very much about the researcher and not very much about the subject or the topic of research. When I think about the way I see my colleagues competing for NIH grants and building their resumes and needing to maintain their tenure and their professional standing, there is nothing about that that is oriented towards helping a community of people. It's very much about helping a personal journey through research and aggregating information. And I find that tragic, and I find that very disconcerting, and it makes me also totally understand why a lot of people in a lot of the communities I work with feel a little bit uncomfortable with participating in research where they have no control over what's going to happen. What would it take to get a research system to share power more meaningfully is a question I sometimes ask. And yeah, I get chuckles usually about that. I try to talk with students about the ideas of theories of disease causation, and I usually say something like, every single one of us is rife with this beautiful bouquet of theories about what happens in health and in well-being and in sickness. And they come from these many different places, which make them very interesting. And if you listen right, you learn about them from the families you serve. We have strong ideas about individual etiologies for some components of our health, the way that we can have a very direct influence on our health by our behaviors and our choices. It really actually allows us sometimes to even blame people for being sick, or allows us sometimes to ask people to take on individual responsibility for everything in their individual bodies. But that's not the only way that we think about illness in this country, even if we're a part of very traditional majority culture. We think about natural etiologies, and we bring science into that, and we think about germ theories and environmental factors. And some cultures think more about humoral factors and things like that, heavenly bodies. These are ideas that are in some ways beyond our control, and they compete with those ideas about individualism and individualistic control based on behavior and things like that. And if you think that anybody falls into one single category, if you listen to their stories and you hear about how they combine this idea of it was out of my control and I had some personal stake in how it happened and my behavior contributes to it, you see how complex we really are when we think about disease causation, and how we can be very supernatural no matter how scientific we think of ourselves. You can think about social ideologies in some of the families I serve where a bad pregnancy outcome to a mom is very much a judgment on her, a judgment on something she has said or did in the previous year, a judgment on someone around her who didn't like her and wanted her to have something bad happen. When I think about that and I try to talk to healthcare providers about how differently you might need to discuss something like cerebral palsy, something like a neonatal disease, it becomes a very, very different conversation, because you can't just say it just happened. You can't just say this was some biologic process that was happening near the delivery time. You really have to try to understand and listen for those cues when a mom is telling you that she blames herself because of something she did in some other interaction. You can see how you as a group are more evolved than most of the students I talked to about this, because all of this must feel really, really familiar to you, really consistent with the lives that you see, the work that you do. Am I right? No? Well, let's keep talking. So in biomedicine, in traditional medicine, I tell people about how much their own medicine has its own culture too, and how interesting that is. How we wear uniforms as if we were part of some military for some culture. We have epaulets in the embroidery of our names on our shirts and things like that. We have our medallions and ceremonial straps that we call stethoscopes. We have these things that we use to make us stand apart, like our language and our desire to make everything end in itis or osis. And we have this, this way of wanting to hold knowledge and mete it out in very small quantities so that we will be seen to forever be the holders of untold amounts of knowledge and never be unknowledgeable about something. That's our culture. And then in that culture comes these things that really create bad outcomes for so many people. We know from evidence that health disparities and the differences with which we treat people changes their lives across the lifespans and has effects on everybody from populations to individuals. That the chance of getting good cancer treatment outcomes varies by the way you're treated based on the color of your skin. That you have to work a lot harder to prove yourself worthy of a kidney transplant if you're African American than if you're not. That it's still true today when you do studies of ER management for pain, and I mean broken leg and very clear, obvious sources of pain, you get different medication, different doses, and different approaches based on the color of your skin. These studies are done every couple of years all across the country, and they keep coming out the same. The people get different treatment based on the race and ethnicity. And this idea that we have a system that is really about privilege, that in the back of our minds, societally, we think some people deserve care and some people don't. Not only that, that we think that some people deserve really good care, and then some people really need to have very moderate care or modest care or almost bad care, and that somehow that will make them aspire to have some greater station in life so that then maybe they'll get good care someday. These are the values that we hold in our society, and I know this because that's the way our machine is designed, right? That's the outcomes that we get, that you get worse care if you're low income, that you get worse care if you're more marginalized. I try to teach students about the history of medicine and how it affects families today. When I went out into our community to talk about school underachievement and ADHD and hyperactivity and inattentiveness, the first thing I got back when I was really able to listen was Tuskegee. And when I understood why that was such an important experience and story to the community I was serving, it really helped me understand a little bit more about how I should approach any kind of disease or any kind of treatment, because this fear that, say, an ADHD medication is a way to keep a young brown person from achieving sounds really crazy when I say it out loud right now, but is exactly the way a lot of families feel when we're talking about treating ADHD. And that those aren't just way back in the past. If you look at lead studies in Baltimore from, I guess, a decade ago now, you see the same outcomes of intentionally kind of allowing people to live in lead-exposed environments so that you could test for the results of those. Those really happened and are happening. These change the way people feel about us and about healthcare. And it's not just in the healthcare system that families feel these experiences every day. I think about this young mom with a baby who had pretty complex heart disease and how hard she and actually her doula and her home visiting nurse had to work to convince the establishment, the cardiologists and the rest of the folks caring for her child that she was doing a good job and being a good mom. And it changed the way people made decisions about surgeries and procedures. The way that that we hear from the Somali community about the issues of autism, again, means to me that we are not listening to a concern very adequately. And you probably know this issue of autism, but in some communities and in some studies, the rates of autism in the East African populations seems higher than it is in the rest of the population. And the roots and the causes for that is really something that should be, I think, very aggressively studied and understood, but it's something that most physicians have no idea about. And it's only the community kind of speaking up and saying, we need some answers about this. Sometimes that shows up with refusing to get MMRs and things like that, which suddenly triggers all of our judgments. But it's coming from this place of something unusual happening in a community and not having the communication skills to understand why that's happening. And if we were having another discussion about autism, I would tell you this amazing thing that I see kids with what we call autism from East Africa actually get cured and have it go away. Just, we don't understand what's happening with that very well. And it's something that we need to sort of spend more time listening and talking about. We think about how throughout our lives we have different influences that affect the way we think and the way we act. And it's sometimes only when you see, say, a reputable op-ed in a Sunday New York Times or a statement that comes from a quarter that maybe shouldn't be wanting to talk about racial bias that you start to get people understanding that the way we treat each other, the way we listen to each other, the way we speak to each other has such an influence on their lives and our lives that we need to pay more attention to that. And there's no group that needs to pay more attention to that than people whose job it is to listen and to respond. It's hard to talk about people in hospitals, talk to people in hospitals about communication and culture and disparities, because a lot of professionals feel like, oh my God, I'm paying for the bad racially biased treatment that somebody else provided, and that's not me, and how come I'm being blamed for that? But these hospitals that I work in, at least the ones I've known, have this very, very tight culture that is not about embracing or inclusion. It's really about really expecting a certain behavior. I don't know if anybody's been at Seattle Children's Hospital, but I have since medical school, and I can say with my own personal authority that you have an expected amount of grief that you can show as a parent when you're in Seattle Children's Hospital. It can be 2 teardrops from your left eye and 3 from your right, but they have to alternate and they have to go at just the right time. If you cry too much, then you are they're worried about you because you are way too emotive. If you cry too little, wow, you don't love your child very much, do you? If you're a single mom who has to work many hours and take care of other kids and you're not there at exactly the time the doctor wants to round, boy, you must not really care too much about your child. A sad truth about Seattle Children's, but something I will give credit to Seattle Children's for knowing, where other hospitals don't, is that if you looked at the rates of what we call code purples, the number of times we call security because we're worried about a parent who's acting out. Those rates are highest among African Americans at Seattle Children's. We are racially biased in the way that we disapprove of emotion at Seattle Children's, and it shows up in our data. And again, I really give credit to the hospital for knowing that and understanding that. But boy, we really have to understand how people communicate grief and be more willing and more open to different forms than we do right now. To have security called when you're really grieving over the illness of your child is one of the greatest injustices I could think of. And yet we do it every day in a very racially disproportionate way. We make impossible choices for people by offering them every single thing that they could possibly want. So your child has this disease and diagnosis. Well, we can do everything. We can put a trach in, we can ventilate them, we can do this, we can put them on this, we can give them that technology, or you could choose nothing. And we don't add much help sometimes in this era of healthcare where we just want to make an offering based on our technology and not based on our hearts or our ability to help. We see people who are stressed out in the healthcare field, and we see how that stress and that struggling comes out in the way that they treat other people. And you see the most kind-hearted people in the world treat patients and families poorly because they don't have the capacity to stop and slow down and listen because their own lives are so full of busyness and difficulty and strife and struggle. So we think about these things, and the natural reaction in the healthcare profession is to want to create a course that you can get credit for, right? For every problem, there is a CE. And so you hear things like cultural competency trainings come up, and it's very like a paper doll. It's very two-dimensional. It's very linear. It looks at vulnerable populations, and sometimes it gives you this idea that once you have done this, then you will pass a test and you will therefore and forever be competent in cultures, which is like one of the weirdest things I've ever heard of. It also actually promotes stereotyping and biases because it just gives you this list of, this is what this certain culture likes to do. We like to handshake, or we don't like to handshake, or we don't want to make eye contact, or we do. There's overgeneralizations that really actually harm interactions and the idea of listening and communicating, in my view. So I prefer this other idea of cultural humility. And I ask people in my corners of healthcare professions to practice cultural humility instead, and it's really hard for them because it's not straightforward. I ask them to sort of bring the idea of culture into their clinical practice. And it doesn't look for cultural traits like cultural competency does, but it actually starts with looking at your own culture and who you are. Spend time sort of understanding yourself before you start trying to understand someone else. My wife, by the way, really likes that I try to do that more now. It's lifelong, so you don't get to get a certificate or a credit or a star on your shoulder every time that you pass a test or something like that. It's actually lifelong learning. Wow, what a concept, right, in healthcare. And it uses awareness and respect. And most importantly, it actually asks you sometimes to give up power, which is the very hardest thing for people in our profession to do sometimes. It acknowledges a power imbalance, and this is especially important, again, because I live in Seattle in the Northwest, where people are often very aw shucks about their power. People actually, they want to see a world where there's so much equilibrium, so much equality of power that they are not powerful, need to deny their own power. And I think that's a mistake, because if you are not recognizing that you have a crazy amount of power when you are in a caring relationship with someone else, then you're not doing them justice and you're at risk for doing them harm. Understanding that power imbalance is especially important in any kind of interaction with somebody that you're trying to help. Aligning your accumulation of knowledge with broadening behavior and attitude and giving up the role of expert are really important ideas. One of the coolest mentors that I ever knew, a nurse practitioner at Harborview, she always would take me aside, especially if I was acting kind of cocky, and she would say, like, remember, Ben, in this profession, we are always students and we are always teachers. That we always embrace both of those roles. And if we don't feel humble enough to be a student in a situation, then we will have too much hubris and we will make mistakes and harm people. The idea of building trust is not something that's talked about in the medical training ever, and is one of the most important components of anything that I've learned about in the clinic. If our clinic did not have the trust of the community we served, we could never do a quarter of the things that we care about doing. And the other side of that, if we do things that undermine trust, then we could never be effective moving forward with any great idea, no matter how good it is. So how do we do all that stuff? How do I tell all students to sort of build on all of those ideas and skills into those moments when we are sharing stories? Those times when we were in clinical situations or when we're just spending time with people we care about. How do we convey our connectedness? How do we show our level of support for the people that we're working with and being around? And that's when we try to focus in on the idea of listening skills and listening abilities. We think about very practical guidelines for some people who have spent so much time studying and maybe emulating practices in healthcare that they've completely forgotten how to listen. And I don't think anybody would doubt me when I told you that by the end of medical school, you've completely forgotten how to listen in that way. So they need really basics, like put yourself in a position to be attentive. Physically put yourself in a place where you can be attentive. Start with and keep an open mind. I know that's very, very hard to do, but when you say that you intend to do that, at least you move closer to having an open mind. When I assumed that the mom taking her kids to Africa was going there to escape urban Seattle. Remove your distractions inside and out. Teaching students and trainees how to find a way to come into a room and leave some of their other things that are on their minds outside of that room. And to make the space a place that is not distracting to the extent that you can. Watching for nonverbal cues. Don't interrupt. How many people have been to a doctor where the doctor did not interrupt? Yeah, I kind of thought. A learning process and a continuing practice that I think we really need to relearn and re-identify with. Asking questions and clarifying. And asking questions is one of the most important ways for somebody to understand that you care about what they're saying. This sounds really basic, but these are the kinds of like ABC skills that need to be sort of retaught to people who have spent so much time cramming ABC options from tests into their heads. Conveying empathy without getting lost in the emotive talk. How to show that you really care about somebody's feelings and what they're going through without getting so wrapped up in your own feelings that you become either a spiraler. Anybody here a spiraler? Where you kind of get caught up in the other person's feelings and you don't make it better? Wow, none of you are spiralers? There's one honest person in the room. A couple of us are also spiralers. But how to also see beyond that emotion and to help somebody else feel more steady by your own steadiness. You think about these qualities of listeners, of good listeners, and how much it is as important a skill to be knowledgeable about pulmonary function as it is to have an accepting stance in the way that you come into an interaction with somebody. How much importance there is on the idea of respect and promoting dignity when you're talking to someone. When you think about it consciously, what can I be doing to help somebody feel respected and dignified? I have to remember this every day because if you've ever been in my clinic, there is a huge painting on the sort of upstairs, and it's a picture of Blanche Levizo, who was the first director of the clinic. She was like a schoolmate of Martin Luther King's growing up. She was a super powerful woman, an incredible person. She got the clinic started, and she listened to some of her first patients, and she said, I'm going to make a clinic that promotes quality care with dignity. And I don't know that dignity had been written into any other mission statement in any other clinic at that time, but the idea of promoting dignity as part of a healthcare practice was something that she understood. And she looks, you have to come to the clinic just to, well, partly to see all the cute kids playing, because that's really cool, but also to see this picture of this woman looking at all of us with such a strong sense of respectful obligation. What are you doing to promote the dignity of the people around you every day? please come to my clinic. You should see that. And also my mom, who just recently retired and used to be a Forest Service worker, but now thinks that she's become an artist, and she's actually a really, really good artist. I made an excuse for her to put her paintings up by putting them up in the clinic, and she does really cool things. So I get to be surrounded by all of these strong women every day. And if I listen and if I'm attentive, then I learn those lessons that I'm supposed to be reminded of every moment. My mom's crazy. She's really cool. Reflective listening skills. Do you talk about or learn about reflective listening skills in your practice or your training? So these are all really familiar comments and statements to you. You'd be surprised. This is nothing that a medical student or a health professional in many other aspects would ever see or talk about, unless you're in like psychiatry. The idea of using good techniques in conversation to show that you're paying attention and listening and caring, like paraphrasing, just to show that you've actually heard what somebody said in terms of content. And reflective feeling, showing that you understand what they're feeling by using it and naming it in that process. By summarizing, not only do you know the content of what somebody said, but you actually understand the ideas and the themes that are coming through that. And that use of questioning to sort of keep a dialogue open and to push somebody from an interesting story to a really meaningful story. You think about all of these components of reflective listening and listening skills and empathy and how they really come into this sort of dynamic that really help. And I will tell you, usually when I put a slide like this up, then medical students start tuning out because it doesn't look like something that would ever show up on an exam for them. We talk about the idea of mindfulness. Do you talk about mindfulness in your training and teachings? Is that a concept and topic that, wow, wonderful. Are you sure I'm supposed to be talking to you, or are you supposed to? Mindfulness sounds like a misspelling to medical students. They don't get ensconced in this idea very much. And so actually defining it and understanding it is something that's important. But not just that, helping them understand what mindfulness really means and how it comes across and what's important about it. And what are the sort of basic essential tenets of mindfulness, how it is about being purposeful, like really having the purposeful intention of being an attentive listener when you walk into an encounter with somebody, how you really work, that becoming non-judgmental to the extent that you can is work, and it's practice, and it's not inherent, at least for most of us, and it's not something that stays if you don't think about it. Being in the moment is something especially difficult to people whose lives are busy and hectic and distracted and full of many tasks and many obligations. The thing that we're trying to work on the most in our clinic these days is how to slow down. We work with families who live in crisis all the time, and we are really good at absorbing that crisis. You and I could work together there because we would spin together with families and we would feel their difficulties and crises, and we would live right there with them all the way through it. And then we would go to lunch with our peers and we would talk about that crisis, and we'd feel crisis in ourselves, and the crisis would be part of it. It'd become organizational in the way that we manage our clinic and treat each other. That this energy that sometimes we're trying to help with is something that sometimes we just completely adopt and normalize into our own functioning. And that idea of stepping back from the edge of crisis, the idea of seeing urgency as something that needs to be actually managed itself, the idea of allowing something to slow down, allowing a process to slow down a little bit, allowing a moment to slow down is kind of magical. And it's a skill, and it's something that's practiced, but it's something that if you understand how important it is, you would do everything possible to try to get things to slow down, because that's when actually people become really helpful. That's when in our work, in our clinic, we move a little bit away from being people who do stuff for other people to people who help people solve their problems and help themselves. And those are really important things to us, because I just think it's very, very egotistical to want to just solve people's problems all the time. And I don't think if we really talked about it, that would be anybody's goal. But that's what happens when we're in the midst of crisis and spinning. Think about the idea of respect and inclusion and dignity, like Blanche Levizo talked about, and how that is such a flip on its head for our culture of competition. How in medicine, especially, there's all of this, what rank are you in your class? What did you get on your MCATs? How did you do on your boards? How do you promote dignity when you spend most of your life trying to differentiate on a hierarchical scale? It's a really hard thing, and it doesn't sound to a medical student like being ensconced in this world of competition makes it hard for them to act inclusive and treat people with dignity until you start thinking about how much those connections influence your practices. Does any of this make any sense to anybody today? Oh, it's one. Okay, great. These ideas are really important, and I really like the importance of cultural humility because it's so different than the way we've practiced medicine for so long. It's so much more about negotiating priorities. It's what I see your world doing so much of the time in relationship to the traditional healthcare system, really looking at how to change some of the paradigms by asking for a different kind of power relationship, by asking for the ability to negotiate situations, by looking for the ways in which something that is meaningful to an individual, a mom, a family, or a community can be brought into the reality of a healthcare system and stay whole on some level. This idea of being willing to compromise is really important. And again, I will tell you, in my field, we have this thing that's called pretend compromise. And that's, that's where folks will say, we're going to do this community-based research and we're really going to be inclusive of the community. And then we go and we talk to the community and we've already got the research all figured out and we already have the protocol all set up and we just want you to say it's okay to do that. And then we call that community-informed participatory research. Then we feel good about the way that we really engage with people. Or compromise, when it comes out for real, becomes really hard. When a family says, I'm willing to do 4 out of these 5 vaccines today, but I want to wait on this other vaccine. That's a judgment moment in our healthcare profession. It shows you how little we're able to compromise in situations, and I think it conveys a message that I don't respect you because you're not doing exactly the way we want to and the way we want to do it. These moments and these ideas are pervasive, and it's very difficult for us to move off of that place because our training has really indoctrinated us into a very strange place. Listening skills and cultural humility are pretty hard to incorporate into the healthcare system also because there aren't traditional learning methods that allow you to embrace and take up ideas like cultural humility or empathy or compassion very easily into something that can be tested on. It's hard to measure how compassionate you are in a way that somebody could reflect that back to you as your attending physician or mentor and talk about that. It's very hard to power share. It's very hard to get away from the idea, I'm a good person, therefore nothing I'm doing could possibly be harmful to anybody. It's very hard to get institutions to self-reflect, which is why I give credit to Children's for to actually know that more often they're calling code purples on families of color than not. And it's very hard to move away from a business construct that mostly pays people to do lots of stuff very often instead of paying people to have meaningful moments and share stories. These are challenges, and there are all kinds of barriers that can happen even outside of the traditional healthcare system that you might face at times as well. The idea of over or under reaching in the way that you want to interact with somebody. The idea that we might have stereotypes even when we are very, very open-minded about things. The way that we might sometimes pretend comprehension, sort of like I did with the mom about why Somali moms are reluctant to get prenatal care. Sometimes we're just not really good at catching nonverbal cues, which is something my wife would accuse me of all the time. And sometimes we get into way too much complexity in the way we want to talk about things, and that creates greater and greater differences. There are lots of barriers like that. And I think especially in the healthcare field, there's this risk for these kinds of barriers as well. These kinds of traps that promote disengagement, this sort of rushing to a judgment really quickly and this assessment gap trap. The idea that we always want to be experts, That goes very much against the idea of being a student of someone else's knowledge and wisdom, and it's very hard to get away from that. And there may be people in this room too, for some of the time, have trouble stepping away from being the expert and returning to being a student of the people around them. The labeling trap and the blaming trap and the chat trap, the devolving sometimes of conversations away from helping somebody with their essential story, and rambling on about, say, maybe about how someone's mom is a painter now and she puts her paintings up in the clinic, and that really didn't have a whole lot to do with talking about listening. These ideas are really complicated to people in the health field. So the solution after you've done your cultural competency training is to give people flashcards, cards that they can put in their ID badge jackets and lanyards and look at periodically. And to tell you the truth, I actually really ask students sometimes to look at these and think about how they would ask these questions, at least one or two of them, because these are questions that never, ever, ever get asked in the traditional healthcare system very much. What do you miss most from before you were ill? What a super important question, right? Why is there not somebody in the medical school training arena teaching somebody to really care about that? Tell me that's not a way to find an amazing story, to share an incredible story with somebody and understand them that much better. Flashcards, not always a bad idea, I realize. We make lots of them too. Sometimes we use ones with cool mnemonics on them, so, you know, get the double message there, like be humble, but you can do it by doing these things. Sometimes students eat those up. And in a way, it is a better way sometimes to remember some important lessons one way or the other. We think about all of these things, and we think about these ideas of privilege and responsibility and how much working in this field is a transforming gift and what we care about in our world. I think it is a profound privilege to experience someone sharing their story. I think it's a personal responsibility that we must hold ourselves accountable to being effective listeners. I think it's a transforming experience to help somebody slow down. You've just manipulated time. That's got to be cool. I think it's a great gift to not carry the full weight of traditional healthcare, and I'm so glad for all of you to have been so much more evolved than my many colleagues. I think it would be a better world if the least empowered consistently got the best healthcare support possible. What kind of a system would that be if we had, you need better care than anybody else because you really, really deserve it? Wouldn't that be an interesting world? What is this term equity you speak of? I think that we need to know that we have power, and with that power comes responsibility. And every time I say that, I can't help thinking that I heard that in a Spider-Man movie. I think his uncle said that to him. So, but it's true in the non-superpower world, in addition to the those with superpowers. I think that we need to teach ourselves and others about the difference between equality and equity. And I think we need to think about how we talk about that every day. I think we all care about being revolutionaries. And I respect your work so much because you are revolutionaries. You are evolutionary revolutionaries, which is one of the most loving ways to be a revolutionary, which is really cool. And I just got tongue-tied saying that. I want to share one more, like, I'm so stupid moment with you about AHA. So this would be like, I would say a year into actually practicing medicine and reflecting back on things that I had learned through my training, and then sitting in a room with a grandma. And it was not until, man, I'm so embarrassed about this. It was not until that moment that I realized that that grandma, when she was pregnant with her child, that's when every bit of the genetic content from mom that was going to go into the grandchild was made. That in that grandma was the life experience and the stroma, the environment, the building blocks, the energy, the warmth, the strata, everything that went into making that little kid from mom's side happened in many ways genetically in grandma. This idea completely blows my mind because this connection, am I the is this not interesting to, you guys all know this, I know, but this idea of generational stuff, and we just think we're finally getting evolved and cool because we're talking about the first 1,000 days and how important it is to think about conception, and maybe one or two people talk about preconception and how important that is. You know, we've got to think about right before you get pregnant and how it's grandma. Grandma really matters. We somehow lose these connections in some of our practice between honoring and respecting wisdom and the gift and sharing that grandma has already made and would continue to make in the lives of younger generations. And it is so wired in there, and I just think it's very fascinating that, not to make your work with mom obsolete, but grandma's also really, really, really important. And those are things that are just really amazing things to think about when you listen to a grandmother and you hear a story and you share a story, and then you see yourself as a student and you reflect back on stuff that you already knew and learned a while ago, and you think about this connection, and I don't know why, but it just kind of blows my mind the way we are. These are the things that are meaningful to me, and I think that the way we think about them is really helpful. When I talk to students, they see it like that, like the idea of being a good listener and being culturally effective and having humility in their practice feels like just a fight that they cannot win. And I have to remind them that the most confident looking person in that dyad there is the little skinny kid, I think. So there's something about this that is really important and really truthful and really not exactly as it seems and really powerful. And that when they slow down and they think about themselves and they think about what they care about in their professions, why they wanted to be in this caring profession, why they want to be in a room with somebody and have that amazing privilege of having a chance to help. When they think about that, then the idea of cultural humility and the idea of learning how to listen again, the idea of being a student forever and taking this lifelong journey, the idea of having these sharing moments with other people you care about and just loving it, just relishing in those times when you're sitting next to them. That's when you become a different person. That's when you have a gift that if you hold on to will serve you for the rest of your life. So that's what I wanted to share today. Thank you for listening.
Okay, I would like to thank you, Dr. Danielson. That was amazing. I'd also like to introduce Jessica Edens. She is a soon-to-be graduate from the Midwifery program at Bastyr University, and she's here to talk to us about laryngeal mask airway and implications for Washington State licensed midwives. Please welcome Jessica. It's already playing, so you're just going to advance it. Is there a pointer? No. There was a pointer. He brought it all with us.
Hi. So I did my master's thesis on the laryngeal mask airway by studying the knowledge, attitudes, and practices of Washington State licensed midwives. So in this presentation, I'm going to tell you about what an LMA or laryngeal mask airway is, I'm going to talk a little bit about the research I did, and then I'm going to hopefully answer your biggest questions about what it is and why you might want to use it, and then show a video about how, or just show a video of how it is used in practice. So, 3 images here. The image, I guess, to your right is the anatomy of the inside of the throat and the pharynx. So where the laryngeal mask airway aims to sit is right below the pharynx, so right over the trachea. That way you're getting the air exactly where you want it to be. And you can see in the baby also right where it is located. That image, I'm sorry, is a little blurry, but it just sits right at the base of the throat. So not going into the bronchi, not going into the trachea, just putting the mask right over that space. And then you can see the device. There's also one being passed around, the elliptical balloon on the end. That's the mask, just like you use a mask that goes over the nose and mouth. It's the same concept. It just goes in the throat. And then there's a attachment where you can take a syringe and fill the balloon up with a little bit of air, which allows it to sit right in the throat so it doesn't move around and become dislodged. And the other end attaches to your ambu bag like the mask that you have now. So where did I get the idea to research this? For my very first NRP class back in first year of midwifery school, I realized we're not doing the whole book. Why aren't we learning chapters 5 through 9 or whatever chapters they are? And I was told it's because out-of-hospital midwives don't do intubation and they don't use those medications, so we don't need to learn about that. And I thought, okay, but should we be doing intubation? Do midwives want to do intubation? You know, I'm new and green and have these unicorns in my eyes and think that midwives can do everything and we should be doing it all, and what are we doing? And it actually turns out when I talk to a lot of midwives that they don't want to be intubating because it's a difficult skill that requires practice, and as you all know, there's not a lot of opportunity to be intubating babies, thankfully. So I was still thinking that there might be some middle ground that would allow us a way to establish an airway that was more effective than bag and mask in those rare instances when we actually need that. And I came across the laryngeal mask airway and thought that that might be a good place to start. So I did a literature review, and I had my master's chair go over this with me, and we thought that seemed like a good idea. So I had the IRB, or I designed a proposal, and the IRB approved it, and then I began recruiting midwives for my study. I sent either a letter or an email to all of the licensed midwives in Washington State that aren't also NDs or CNMs or EMTs or any other kind of dual license provider. And unfortunately, I only got 11 responses after 3 rounds of emails, and I was able to complete 7 interviews. So the response rate was a bit disappointing just because most of the people I ended up interviewing were urban-based multi-midwife practice midwives, and I think my results might have been different had I had a wider sample of the midwives in the state. I did find some interesting results. The 2 most relevant here are that only 2 of the midwives had any training with the LMA, but 5 out of the 7 were either interested or very interested in becoming trained or maintaining their training. So your questions about the LMA, the first one might be, is the LMA effective? So there has been research on the LMA, not nearly as much as there is on, say, endotracheal intubation, but the research that we have does point to the LMA being an effective tool for establishing ventilation or an airway in a newborn. The study here that's on the graph was a meta-analysis of 4 randomized controlled trials. They took 275 babies that needed extra help after birth on them, put them on the LMA, and 234 on bag and mask. And then they compared how many of those babies needed to be intubated and how many of the resuscitations were successful or were unsuccessful. So you can see in the graph that far less babies needed to be intubated, and there were far less unsuccessful intubations with the laryngeal mask airway as compared to bag and mask. So that was out of 4 randomized controlled trials. There were also a few other studies in my literature review that pointed to the same sort of results, that there were less insertion time, the insertion times were lower, and the injury to the babies were lower. Also, another benefit is gastric distension that you can get from bag and mask ventilation is much less likely with the laryngeal mask airway, because if you think about where the mask is, it's right over the trachea, so less likely to get a lot of air into the stomach. And I have a full list of all of my references and everything. If anybody wants to see those, it's available at the Bastyr Library or on ProQuest, or you can read my paper copy. Another question you might have is the LMA a safe device for LMs to be using? So of course, there's no studies about specifically midwives and out-of-hospital birth out there, but there are studies on paramedics who are practicing in a pre-hospital setting outside of the hospital. They also don't have very many opportunities to intubate babies. So there have been some studies done on paramedics and using the LMA and if it's effective or more effective than intubation. And those studies have also found that the LMA, you can see there, is faster for the paramedics. They were faster using the LMA. They needed less insertion attempts, and they actually preferred to use the LMA over the ETT tube because it's easier to use and more, it's not foolproof, but it is fool resistant. Thank you. So again, there are more studies that kind of all point to this same thing, that if there's not a skilled provider to use an endotracheal intubation to be able to do that in the room, then the next best option is the LMA. And another question you could have is, do other people support this? Do our kind of guiding bodies support the LMA? They do. The LMA actually is in the neonatal resuscitation handbook. It is in chapter 6, which unfortunately is not part of what we have to learn as out-of-hospital providers or licensed midwives. But I proposed in my research that it be moved to chapter 3 because it is such an easy to use, safe, and effective device that I think it would be great if all student midwives and midwives going forward had to learn about this in their trainings. It's also on the list that the American Academy of Pediatrics states should be at all births, part of the equipment that should be there. Also, of course, the Council as well. They also say that tracheal intubation is the best way to establish an airway, but if a person who is not skilled in tracheal intubation isn't present, then a supraglottic airway device or an LMA is acceptable. And maybe your final and most important question is the LMA in your scope of practice? The answer is yes. The Legends of Drugs and Devices for Licensed Midwives states that LM may carry any equipment for adult and infant resuscitation. So there's no specifics listed here. It just says equipment for resuscitation, which I think is a smart move because that allows us to incorporate new devices and techniques and knowledge into our scope without having to change the law. All right, and finally, we have a video here. It's only a couple of minutes long. Oh, can you hear it?
Correct insertion technique for the intersurgical solus laryngeal mask airway. Firstly, it is important that
Okay.
you select the correct size for each patient.
Can you hear that?
And the patient weight does appear on the airway tube. Next, prepare the laryngeal mask airway by fully deflating it to a very tight vacuum. Contrary to some popular beliefs that there should be some air in the cuff, this is not so because a filled cuff can collide with the epiglottis. Next, prepare the solus for insertion by putting some gel or lubricant on the back of the cuff. Just on the tip of the backplate is all that is required. Then, in readiness for the correct insertion technique, insert your index finger into the slot formed behind the flattened cuff and the junction with the airway tube. Then prepare the patient by tilting the head back and bring the tip of the laryngeal mask airway laterally towards the patient, not downwards, but resting the tip behind the teeth and gums because you're going to utilize first the hard and then the soft palate of the patient to perform a sweeping action that optimizes the anatomy as an introducer tool. Inserting the laryngeal mask vertically or obliquely brings about difficulties, but by following the curve created by the palate rather than bouncing off the back of the throat is by far the simplest method of effective insertion. So we are ready now to start inserting the laryngeal mask airway. And there you see it, following the natural curvature with the finger going as far as it can, and then using the other hand to stabilize the laryngeal mask as you remove the introducing finger. Then with a pre-prepared syringe, inflate the correct volume. You'll notice that not only is the cuff inflating in the pharyngeal cavity, but the connector is also rising slightly, which is an indicator that the laryngeal mask has been fully inserted. The tip of the cuff is now sitting over the esophagus, which is acting as a form of partial stopper, either against reflux coming up or possible minor leakage of gases into the stomach. The epiglottis is resting over the top of the cuff, and the whole of that section is now completely filling the pharynx, which is a special feature of the laryngeal mask airway, because now the nitrous oxide or other gases are being directed solely through the trachea and into the lungs.
See, pretty easy. And on a baby, everything is smaller. So in this case, it might actually be easier on a baby than on an adult. And lastly, if this triggered your interest and you would like to learn how to use a laryngeal mask airway, you can at any NRP course where you take the entire course. So that can be at the UW ISIS Lab, Swedish, Seattle Children's, or Sacred Heart Medical Center in Spokane. I'm sure there are others as well. And I was also hoping to get a show of hands if any of you who don't necessarily need the whole training but would just like to learn to use this device would like a midwife focused half-an-hour training session. Anybody out there? Oh, wonderful. Look for that coming in your future then. And that's all. So any questions? I did that 5 minutes faster than in all my practices, so sorry if I talked too quickly. No question? Okay. Yep. So she's asking, your first thought is probably going to be to go to your bag and mask, and when to switch over to the LMA. Yeah. So if a baby only needs, you probably are going to know from the beginning, is the baby going to need 1 or 2 puffs? If so, use the bag and mask. Don't go for this. This is more for when you've done a couple of puffs and you're like, this baby doesn't look like he or she's coming around. You might be starting CPR. You might be calling 911. That's when I would do the switch. So this is definitely not for your typical, it just needs a little bit of help to start breathing. Yeah.
I have 3 birthing centers, and after being with our local hospital, what the practice guide that we have is that we start the LMA when we call if we're going to transport the baby. So,
yeah.
And we have found that it's made the transport so much smoother. And we also got one of those car seats, the flat car seat, so we can prepare the baby for transport. We have the LMA in, and we put the baby on the bed, and then that way EMS is really just acting as they let us continue where before they would come in and want to take over the recess, and it was always the best thing that would happen. And so now that we can use the LMA and use the baby on bed, they see that we've got an airway that is not the bag and mask, and they just take us to the hospital. So it's worked out really well. We love the LMA.
That sounds awesome. We should talk. Anybody else? All right. Thank you.
Thank you, Jessica. Yeah. I'd like to introduce Christina Windorf. Christina and her husband Jason are the parents of 1 girl and 3 boys. Their oldest son Kai was diagnosed with moderate bilateral sensory neural hearing loss at 4 months. Christina currently works with Washington State Hands and Voices, providing unbiased emotional support and resources to other families whose child has been identified as deaf or hard of hearing. She's here to share with us today. Thank you very much, Christina.
This will take a second. You guys have been sitting for a while. If you want to get up and shake, go ahead.
Do you need to plug in? Plug down here. I'll grab this for you.
Do you want to put it on this side? Yes, that's for you. Oh. Can you see? Yeah. Good job. Good job. I know.
We're getting a weaker connection. It doesn't want to stay. It's not this.
Oh, I don't think it needs to.
Well, it was
There we
kind of
go.
pretty wiggly. Oh. Okay, it's working.
Hey,
Oops, no, it's not.
Oh, yeah, see, it's really, really wiggly.
do you want to put it on the table? I don't need it then.
Is that easier for you? It might work better.
There's water right
Let me see if there's.
It's this cord. It's not your. It's the cord.
It is the
Do you have an HDMI cord?
there. I definitely don't need it there, so if it's easier to have it.
Let's use your jump drive.
I have this talk set up on that computer, but now I need Amanda to log into her computer.
From it. From it. CROMIT.
They get a little extra break. Yeah.
You need it.
It's a long time to sit.
I just think this is gonna come off, and I don't want to.
Okay for you. On here.
Yeah, totally. It should be fine.
Okay, let's just
I'm
do
not
that.
super tech savvy, but
You're just gonna press the space bar.
perfect.
Okay.
And there's a break after me, right? So I can clean up all my crap then.
Yeah.
Okay.
Good job. Okay, we're good.
Lena, how did she do sound?
She just held
The
it.
mic and
Take
held
the mic.
it.
Where's your speaker?
The
I don't know, this
speaker's
isn't mine.
going to be coming out of this area,
That,
so
okay, just this
this was the one she was using. Go like this.
Okay. Can I get like a napkin?
Yeah, I'll go grab you one. Just make sure it's working, and then I'll walk away. Yeah.
Okay, thank you.
Okay.
So I just hit the space bar?
Yeah.
Okay. Well, I asked them if I needed to do it, and they said that they were just letting them mingle. Apparently they need it. Yes, I guess, which I'm totally fine with. My kids are taken care of. It's like a mini vacation to be here. Thank you. anybody, but I'm
Oh,
sure they can
no,
talk
this
for a little
group,
bit.
yeah.
Chatties.
So I want to let you all know that there's actually a party after this conference, and it's a great place to socialize. But right now, Christina's ready to go ahead with her presentation. So if you could make your way back to your seat and bring the conversation down, that'd be wonderful. Thank you. Okay. Please welcome Christina Windorf.
Hey there. My name's Christina. I know a few people here who've gone through Bastyr have heard me talk, so I will try and be entertaining so that it's not repetitive. I turned on the track light because I felt really dark and dreary up here. So if you can't see the slide, I heard you can text people and tell them or something. So I'm not going to make you read anything. You're just going to have to mostly listen. So, but if it's hard to see, please let me know. Because this is basically my family photo album. So it's my pleasure and my honor to be here. And I just appreciate the opportunity to talk. So this is my family. And we call ourselves Team Windorf because we just kept having babies. And we had 4 in 4 years. And I really believe this is our family story, but it centers mostly around our second born. So our daughter is in the pink. Her name is Lucia. The deal was girl names get to be Italian, boy names get to be German. I kind of lost out on that one. So then Kai is standing right next to Lucia in the, well, I guess one of the hats. And then I'm holding Otto. And then Axel's in the Spider-Man hat. He's our youngest. He just turned 6. Although he has a big head, just like Kai. Okay, so this is Kai. But first, I'm actually going to tell you about Lucia. I have notes because I am really chatty and I tend to just keep talking and I could keep you here all night. So I'm going to try and stick to my notes. Okay, so Lucia was born at a birth center in Everett, and I have a history of passing out due to an over-imaginative brain. So I went the less is more method. I read 1 book. I took 0 classes. I really wanted my husband to be the one that was like super knowledgeable and had strong opinions. And he was like, babe, I love you, but my only plan is to get you to Charlotte. And we know when they sit you down, like when you're, I don't know, 30 weeks or something, and they say, okay, here's what you do. If you have to have the baby in the car, he's like, that's not gonna happen. So, I kind of got over the fact that he wasn't going to be who I imagined him to be. And we as a family clearly weren't big planners. And that became apparent every time we were surprised by a new pregnancy. So, okay, so Lucia was born at a birth center in Everett, and I won't tell you the labor details, but pushed for 6 hours, and out popped a very alert, non-crying daughter. We joked that she was, like, from the start, just judging everybody. She's my hard-hearted girl. So, you know, very typical birth center. We were home 12 hours later, even after hemorrhaging and blah, blah, blah. So she was super articulate, off the charts vocabulary, and even at 14 months when her brother came along. So I got pregnant with Kai, I don't know, around 6 months. And he just felt like he was going to fall out the whole time. And now I think it's just because his head is ginormous. But so one day I wake up, maybe like 33 weeks, and I'm trying to remember, is this what a contraction feels like? I mean, it had barely been a year. You'd think I'd remember. And so by the time my husband got home from work, he's like, hey, how was your day? I'm like, hold on a minute. And he totally freaked out. He was like, get inside, call the midwife. So the contractions weren't stopping, so we went to the U, and our plan was just to tell them that I think I have a bladder infection. Can you stop the labor? And I was like 9 centimeters. So our midwife flew, she did not get a ticket, thank goodness. Made it just in time. It was just crazy, total circus at the U. And there's like 900 people in there because it's a training hospital, and everything is sterile and metal, and they're like, don't push, your water hasn't broke. And my midwife's like, just do it. And so I pushed and just sprayed everybody, and out shoots Kai, and it was very dramatic. And so they give him to me to nurse, and they test his sugar, and they're like, oh my gosh. So they send him up to the NICU because they said his sugar was really low, and it turns out it wasn't. But once you're in the NICU, then you can't just pull him out. So we spent a week at the U, and it wasn't a great week. And he went from the NICU to the nurse's station on my floor, then in my room. So finally, they're going to let us go home, but there was something called the newborn hearing screen that was standing in our way. So they came in and they're like, look, we're not sure if he passed, he might have failed, and you're not supposed to use that word, fail. And I was like, what are you talking about? My daughter's really smart, and we've never had this thing done, and I just want to go home. I tend to be really mean to most everybody. So I was just super cranky, like I just want to leave. And so they're like, well, we're going to do it one more time. But earlier in the week, I was in the nurses, what do they call it, a nurses station? I don't know. So I was in that room, and I was trying to nurse Kai, and a nurse dropped a clipboard, and he totally jumped and startled. And the nurse, not knowing anything about the newborn hearing screen, said, well, there's nothing wrong with his hearing. So when they came and told me, he hasn't passed this thing called a newborn hearing screen, I was like, I don't care, because in my brain, all I knew about hearing loss was either you're deaf or you're not, right? Because you don't know what you don't know. Okay, so I just really like this picture. So we left the hospital with inconclusive test results, and they told us, well, most likely it's fluid because he was 6 weeks early. So again, not really giving much thought to the whole inconclusive newborn hearing screen test results, we went home. So the UW has a pediatric audiology department, and they called to follow up. And they said, oh, we heard that you had these inconclusive test results. We want you to come back in for a screen. And I said, no. Because they said we only have afternoon appointments. And I was like, listen, I have got 2 babies here that nap in the afternoon. I am not leaving my house. And they said, well, we'd really like you to. And I was like, well, is it mandatory? And they said, no. And I said, well, then I'm not coming. See, I'm not really a nice person. So I did not get a rescreen, but then they tattletaled on me to my naturopath, who was like, look, just go. Here's a list of other places. So I made an appointment at Virginia Mason. He had inconclusive results again, but I had all these reasons why. Like, a grad student did it, and my daughter was chatty, and he had the binky, and whatever. But because he had now failed the screen, or not passed the screen twice, they sent us on for further diagnostic evaluation at Children's. So at 4 months, we ended up at Children's, and there's a whole bunch of stuff I could tell you in the middle, but I won't. So this next test was called a BEAR, and I'm going to give you more information about what the newborn hearing screen, how it's performed, and the acronyms. But anyway, so we had this BEAR test done. After an hour and a half, they told us, well, your son has a mild to moderate bisensory neural hearing loss. Here's a handshake, a hug, and a pamphlet, and we'll see you in 6 weeks. And I was like, what? So that was kind of the start of our journey. These are not my babies. Obviously, my babies are blonde. Okay, so this first picture is of the newborn hearing screen, and it's called an OAE. So I'm not an audiologist, by the way. So I'm sure that there are people in the hearing sciences world that could do a much better job of explaining this, but this is my mom perspective. Okay, so it says an OAE are sounds given off by the inner ear when the cochlea is stimulated by a sound. I should have had a picture of an ear up here. Sorry. Okay, so just Google that. So when sound stimulates the cochlea, the outer hair cells vibrate, and they're going to produce these inaudible sounds back to the middle ear. And the sound is measured with that small probe that's inserted into the ear canal. So people with normal, typical hearing, they produce these really soft sounds, but anybody with greater than a 20 to 30 decibel hearing loss does not produce these sounds. So after 2 tries and there's no response, the babies should be referred for another screen, because you don't want to just, let's try it again, because that's annoying. So the OAE, which is what the newborn hearing screen is called, it can detect blockage or fluid, like the nurse told us, but it's really there to tell you if there is damage to those outer hair cells that are not sending these quiet little sounds. So when the baby does not pass the OAE and they're referred for further diagnostic evaluation, that is when they're conducting the second test, which is called an ABR, an auditory brain stem response. It's also called a BAER, BAER. I also learned that it sometimes is called an AEP, auditory evoked something. Hold on, I'll tell you. Maybe I'll tell you. Auditory evoked potential. Yes, thank you. I just learned that when I was studying for this. Okay, so the auditory brainstem response, they have the picture of the baby in the little unit it looks like, but you can, most moms hold their babies while this happens. And for both tests, the babies, it's preferable if they're sleeping or just resting really comfortably and not making any noise. So for the ABR, they put electrodes on various parts of the baby's head, which, you know, I admit that was pretty like, I didn't really want to see my kid looking like a science experiment. So, but they stick the electrodes on different parts of your brain, and then it just records brainwave activity in response to the sound. So it's still non-invasive, and the baby sleeping doesn't feel anything, but this can determine the degree of hearing loss. So with the newborn hearing screen, it's just telling you, is there any damage to those hair cells? And, but it's not telling you the degree of hearing loss. Okay, so I think that one thing that we really walked away learning, and something that I really am impassioned to tell you about, is that if you are the one screening, you need to remain neutral, right? Because all I remembered was that that nurse said, there's probably fluid in his ears. That is why I was not in a hurry to go back for a rescreen. That was why I was determined that, you know, I was determined to prove that he did not need a diagnostic evaluation. So, when Axel was born, like there was a situation going on with my body, and I sat down with my doctor, and she's like, look, it could be an infection, could be something else, could be cancer. She didn't try and scare me. She just simply laid out my options, right? Like, but we're going to do further diagnostic evaluations to rule out or determine which one of these it could be. As a mom, the word hearing loss or deafness might scare me, but I don't want to not hear it because you're worried about my feelings, right? Like, I need to know my options. And so if you are performing the screen and the baby doesn't emit those tiny sounds, you can tell the parent, okay, we're gonna try this again, and then we're gonna refer you for further testing, because it could be blockage, it could be fluid, but it could also be hearing loss. And so I just encourage you not to minimize the possibility that this could happen. I mean, yeah, anyway, okay. I've also heard of an example when, and as midwives, I'm sure you're not gonna screen, 20 babies a day. And so it's not gonna happen very often when you don't get response. And so I did hear a story about how there was a situation, the person testing got no response, but that had never happened before. So they told the parent, I think the machine is broken. and it could have been, but really the baby was severe to profoundly deaf. So just your words are really powerful. And I know in the heat of the moment, I have major, issues controlling what comes out of my mouth. So I know that it's hard in those moments to think, okay, what am I going to say here that's going to impact this family, possibly for a lifetime? But you have power. So use it wisely. Yes. So when Otto was born, we were back up at the birth center. We were ready to do a home birth, but we had this guy living in our basement who was kind of a hermit, and we thought we'd totally freak him out. So we went back up to the birth center for Otto, and I didn't do a newborn hearing screen. I just waited till he was about 6 weeks old. I went to our audiologist, who was our new best friend, and we did a BAER there. And I was pretty prepared for him to have hearing loss. And he didn't. And they came back, and Kai was 18 months, almost to the day. See, not good planners, almost to the day. And they told me he didn't have hearing loss, and I just sobbed. And I realized that I had never grieved the loss of Normal and Kai. And I know that as midwives, you experience messiness all the time, right? With moms and postpartum and just the stuff that leads up to birth. And I just so love you guys, because you are just the most lovely, calmest people I've ever encountered. And so I think if you continue to walk through these families' lives with them, and you are there, or you are in their life when they receive news like this, oh my gosh, what a blessing you're going to be to these families. So Axe was born. Apparently my uterus was tired and my cord prolapsed, so I had to have an emergency C-section. And they came in to do the newborn hearing screen, and I was like, don't touch him. I'm like, I have hearing loss in my family. See, again, I am just not nice to these poor medical people. So anyway, so same thing with Axe. I went and I took him and I had a bear done. And the poor woman was like, I do this all the time. I know how to do it. I'm not going to hurt him. And I was like, don't touch his ears. I was also on pain meds. So that's kind of my excuse for that. Okay. So I'm going to explain to you a little bit more about kind of why we do newborn hearing screens, or where it kind of came from. I'm going to read this because this just isn't something that is in my brain. So in 1993, NIH held a conference, which was a landmark move that endorsed the screening of all newborns for hearing loss before the child leaves the hospital. And then in 1999, Congress passed a Newborn and Infant Hearing Screening and Intervention Act, which helps the coordination of funding of statewide programs. So then so that was 93 and 97, but in 1990, something called the JCIH was formed, and this is the Joint Committee for Infant Hearing. And so that's, I think, when NIH held that conference, that was the majority of people that were there. And these are just professionals in the field of hearing and deafness, or hearing loss and deafness. So then in 2000, the JCIH created the guidelines and principles for the National EDI program. So people clearly were aware that, because up until this point, babies were only screened if it looked like they had some kind of syndrome or marker for hearing loss or deafness. And this clearly was proving to be problematic as these babies with hearing loss got older and were having cognitive delay and speech delay and emotional delay and all this stuff that could have been prevented if the hearing loss was caught sooner. So in 2000, the EDI program was founded, and it's national, and every state created their own EDI program. Our state thinks they're really clever, and they added an extra D. So it's early hearing loss detection, and then our state has diagnosis and then intervention. I don't know why there's an extra D, but I mean, I guess it's relevant. Okay, so nationally, the EDI program has a 1-3-6 timeline, and that means that all newborns should be screened by 1 month, re-screened, and have diagnostic evaluations done by 3 months, and then in early intervention by 6 months. And I'll talk a little bit more about what early intervention means. So in our state, EDI is run through the Department of Health Genetics portion of the Department of Health. I'm actually not sure if that's consistent across the United States. It's probably not, but half of the kids with hearing loss have no identifiable markers, and that was us. Our family had no history of hearing loss. We had no framework for what it meant, but I knew that I wanted to be able to communicate with my child. Okay, so we know our child has hearing loss. What's next? When your child is identified with hearing loss, it's going to look different depending on where you live, the programs that you're plugged into, but it should look somewhat similar. So, okay, so by the grace of God, we were able to meet the 1-3-6 timeline.
And by 6 months of age, we chose listening and spoken language for Kai, and he had his first pair of loaner hearing aids, and you can kind of see, can you see with the lights on? Man, that is a giant picture of his head. Okay, and he had this really cool blonde mohawk. He came out with that blonde mohawk. Isn't it great? Okay, so Kai was identified with hearing loss, and the state assigns us an FRC, a Family Resource Coordinator, and that is true for any baby born with a disability, right? They're supposed to kind of walk you through the steps of how to get services for your child. The FRC came to our house and said, okay, you live in King County, here are your choices. And she gave me folders for an ASL program, a listening and spoken language program, and a total communications program. First, she said the word early intervention, which, hello, I had no idea what that meant. And then she told me, well, this program, they're going through transition, so really, I wouldn't even call them. So that kind of took one program off the table. So then I had to choose between ASL and listening and spoken language. I had no idea. I had no idea what a moderate hearing loss meant, early intervention, listening and spoken language. It was basically there were really, really big choices to make with very little knowledge. And how much time do I have? Anyway, through my parents who live in Ohio's next door neighbor, we talked to this woman who's like a rock star in the field of audiology and listening and spoken language, and that's kind of how we ended up at our early intervention program. I could have just looked at the pamphlets she gave me, but I didn't understand them. I needed someone else to explain it. So because our daughter was very verbal, and because at this point his hearing loss was mild to moderate, and we knew that hearing aids would provide him access to sound, we chose listening and spoken language. And I want to be clear, I am not at all advocating that is always the best mode of communication, but it was for our family. So we got an early intervention therapist, and she came to our house every week for 3 years. And she was like oh gosh, I would just cut off my arm for that woman. So the interventionist and the audiologist, they were like family members those first 3 years of our life. So the little part that's stuck inside Kai's ear, that's called, that's his ear mold. And I have a whole bag full of ear molds. A little bit gross because they were in his ear for a long time. So some of them I haven't cleaned, and you can like see the wax residue on the end. Actually, a couple weeks ago, Kai was like, this one hearing aid really isn't working. And I was like, really? Which has never been the case. Like, it's always a battery issue, and we change them religiously every Monday. And I was like, that is really weird. Well, maybe we should send it in for repairs. And I said, maybe just go try and put new batteries in. He takes it out, huge chunk of wax clogging the hole. I'm like, dude, so gross. So, I'm going to pass these around. You can totally touch them. He's never going to put these in his ears again. There's also some like fun stickers in here and some hearing aid batteries. Ooh. Okay. Well, I'll tell you what. Okay, I'm going to pass around his first pair of official hearing aids. Again, he's not going to wear these again, but still be gentle with them. The one that has an ear mold attached, the battery is in it and it's on. So I don't care if you stick this in your ear or if you put it real close to your ear, you can hear. It's not going to be exactly how Kai hears, obviously, but it's interesting. So go ahead and do that. And then also, I'll talk about this later. There are these other random pieces. And then, okay, so this is something called ear gear. This is what he puts over his hearing aids if he's going to play soccer in the rain, because we have to do something to try and keep them from being destroyed by water. I'll talk more about that too. Okay, but I'm going to pass this bag of goodies around. I don't really care about the ear molds, but I do care about the hearing aids. Okay, so because your ear canal grows really fast within the first 2 years of your life, and there's a foreign object stuck inside it, your ear canal, we had to have the ear molds remade like every 2 to 3 months. So we were seeing our audiologist on a regular basis, our early intervention on a weekly basis. So these people were like family. Okay, I'm gonna really hope that this works. Oh yeah. Okay, so this is the day Kai got his hearing aids, and my mom sent him this really obnoxious toy that makes noise. This is the second, like I played it once and he made this really great face, so I was like, oh my gosh, I have to record this. So I guess you don't really need to hear the noise that it's making, but oh yeah. Gosh, that's still pretty dark. I don't know how to make it lighter. Okay. I don't know. Use the link. Just seeing if I can bring it up. Well, that's weird. Okay, hold on. I'm really not tech savvy, in case you haven't figured that out. How do I make this bigger? Here, we'll just go like this. It doesn't really matter. Oh, green thing. Oh, green thing. Okay. Okay, it's not working. Should it be working? Sad. This didn't even work when I did it last year either. Okay, well, I really thought I had figured this out, so I apologize. How do I go back? Oh. Okay, well, in that cute little video that I don't get to show you, I don't know what's happening. Okay, they told me there'd be a tech person here because I made it really clear that I was not tech savvy, even though that's what my husband does. He just shakes his head at me. I was just going to show you Kai's reaction when he first kind of heard the sound that was coming out of the toy. It was pretty amazing, right? Like he just couldn't, what is this? He's just kind of shocked. So once Kai got his loaner hearing aids, we had to teach him everything. We had to teach him to turn when his name was called. We had to teach him to turn his head toward any sound that he heard to localize the sound. And ironically, we gave our hard of hearing baby a name that just kind of evaporated when you said it, like Kai. And it also rhymes with hi. So the poor kid was very confused. But we filled our home with sound and language. And I love this picture because it shows Kai truly engaged in the world. This picture was what he looked like before he had hearing aids, right? Like he never really knew where the action was coming from unless you were really close to his face. And we had people tell us, man, we've never seen a baby look so closely at our face. And that was just because he was trying to figure out what in the world is going on. And so once he got hearing aids, this is how he looked. And so I just absolutely love this picture. A few months later, Kai got his own set of hearing aids, which are the ones that we're passing around, that I'm passing around, the cool gray ones. Here is what I know. Every mom wants to know their child more than anything knows that they're loved. Knowing that my son most likely never heard my voice in utero, that is heartbreaking. And knowing that until he was 4 months old, I was in complete denial that he had hearing loss, convinced that he was fine, that is really humbling. And I never want another mom to feel those emotions, which I get is unrealistic, right? Because as parents, at some point, we experience those emotions, but it should never happen because they weren't informed or educated or given the chance to know, to find out early if their child had hearing loss. I also love this picture. I mean, really, I just love all the pictures. But Kai is a daddy's boy in every way. It drives me batty. And part of me thinks that's because he was able to hear Jason better in utero, and part of me thinks it's just because they literally are the same person. They share all the same DNA. So newborn hearing screens are not mandatory in the state of Washington, but they are in 43 other states, including Puerto Rico. But because of the EDDI program, by 2006, when Kai was born, there were 69 birthing hospitals, and 66 of them were conducting the newborn hearing screens and reporting the results to the Department of Health EDDI. The 3 that weren't were military hospitals. So today, there are 63 birthing hospitals, 61 conduct the newborn hearing screens, report the results along with their blood spot card to EDDI. The 2 that don't report are naval hospitals. It doesn't mean that every baby that is tested and the results are recorded or reported to EDDI. That doesn't mean that the child isn't identified with hearing loss later in life. And it doesn't even mean if they do not pass the newborn hearing screen that they're not followed up on. There's a huge loss to follow up in this state. I think 2 years ago, it was as high as 25%. So of babies who did not pass the newborn hearing screen, 25% were not followed up on. That is ridiculous. But EDDI has worked really hard, and I think now the number's in the teens, 13, 18, something like that. So when a baby is born outside the hospital, right, it's because the family, like mine, they want a calm environment, they want a less invasive approach, they want more control over their birthing story. That's what we wanted, and that's totally what we had. When I got home from the U with Kai, I did not want to go anywhere to be rescreened, and I will always feel guilty for that. So this is where your job is hard, right? You spend months loving these mamas and helping them grow these miracles inside them. You have a relationship with them that is unrivaled. I would do anything my midwife told me. I still would. So I am asking you to please encourage your moms to follow up and get their new blessings a newborn hearing screen, because I don't want them to wonder if their baby hears their I love yous. 1 to 3 in every 1,000 births, the baby has hearing loss. And right now, 40% of out-of-hospital births are being screened, only 40%. So the newborn hearing screen, it is not a test, it is not a treatment, it is just a screen, it's not invasive, and it only takes minutes. So it's really important for you to know about the EDDI timeline and about the newborn hearing screen. And I know that most of your babies will have pediatricians, probably before they're born, because most people are planners, not unlike myself. But you have a very unique and special relationship with these families and their baby. So you might be the person to conduct the newborn hearing screen, or you might just be the person at their 6-week follow-up to say, hey, how is your baby nursing? How is your body feeling? Have you had the newborn hearing screen? It's just that simple. I'm gonna try really hard not to cry. So in the end, whether your baby is born in a hospital or a birth center or your home, we all want healthy babies. And part of that is making sure that they can communicate with their families from the moment that they enter the world. So the data for 2014, not data complete yet. So in 2013, there were 2,914 out-of-hospital births, and about 40% were screened. So according to the data, that means at least 3 babies left your care with hearing loss that went undiagnosed. So I know 3 seems like a really insignificant number, but it's not to the families whose babies are now going to have a late hearing loss diagnosis. And in the past, that was the norm, but it's not anymore, and it shouldn't be, because language, I know you know this, but language development is so crucial before they're 3. Brain development is so crucial before they're 3. So as far as Washington State, the green dots, can you see that? Yeah, that's huge. So the green dots are where there are midwifery practices with hearing and screening equipment. And in your packet on blue paper, you have this list. So these are all the sites where newborn hearing screens are conducted in the state of Washington. And the midwifery sites are on here. So if you are not already in partnership with a midwife that is screening or another facility, you can find them on this sheet. I know that there's a couple midwives that screen and they just pick a day, right? And they'll say, well, on Tuesdays, I'm always screening. And so you can tell your patients, all you have to do is, call, make an appointment, you walk in, it takes a couple minutes. It's nothing that they should fear or feel like it's gonna hurt them, their time, or their baby. But I get it, right? Like I was that mom who didn't wanna leave, I didn't wanna do anything, I was totally convinced I knew my baby. If the baby needs further diagnostic evaluation, so if it has the screen and it does not pass, and it has the screen again and it does not pass, then that baby needs to be referred for the BEAR or the ABR, and this is the list of clinics also in your folder that does the diagnostic testing. I know that not everybody, depending on where they live, has access to a pediatric audiologist, so if the baby, in my opinion, I probably shouldn't say this, but in my opinion, if the baby does indeed have hearing loss, no matter what the degree, I would encourage your families to find a pediatric audiologist after the diagnostic evaluation. I think it just makes life a little easier for the family to see an audiologist who has more practice with infants and kids. So if you meet a mom like me who's like, I don't like anybody, my husband and I wrote this letter that is also in your packet, just not to scare parents at all, but just to tell them our story and say, we get it, we understand where you're at, we were there, but this is really important. You can share this with anybody you know, people in different states. You can plagiarize it, I don't care. Like, we just want moms to know that this is important and it's a reality. So this is an audiogram. I don't know if you have ever needed to see one of these before, but this blue area is called the speech banana. Kai's hearing loss starts right below the blue and just kind of follows it around. So they call his hearing loss a cookie bite hearing loss, right? Because when you chomp and a cookie leaves a cute little smiley face. Although that never seems to happen in my house, it's just like crumbs everywhere. So without Kai's hearing aids, he has very little access to any of the speech sounds. You can see where they're listed, right? They're in the blue, and Kai's hearing loss starts below the blue. So that means had he not gone diagnosed, he could have been 3 or even 5 before his hearing loss was identified, and he would have had major speech, articulation, communication delays and gaps that would have 40% of the kids with hearing loss that go into school with delays never catch up. That's crazy when it could have been avoided and caught early. Aside from those children who have late onset hearing loss, which is also a reality. So when Kai is wearing his hearing aids and you are within his speech bubble, which means within a 3-foot radius and at the same level as his mics, he has great access to sound. And it's about 20 decibels all the way across. I think maybe even 15 in the higher frequencies. So he has great access to sound when he's wearing his hearing aids and there's absolutely no noise and you are within 3 feet at his same level. The odds of that happening all the time, that's ridiculous. So what I have come to understand is that although his hearing loss is about sound and what he hears, it is more about the brain. And I'm sure you guys understood that a long time ago, but it took me like 7 years to figure out that it was really about his brain. And 80% of how we learn is from things we hear in the background. And that world is really limited to Kai and has been and always will be. And 70% of his school day of how kids learn is from things they hear reiterated by his peers, he doesn't have access to that because his teacher is mic'd. So this is our fancy mic. The mics they use in the school look a little bit different. This is called the Roger. And in any kind of academic setting, soccer, baseball, his coaches, they all wear this, right? So it just goes around the neck. It's at the same height on everybody. And there's a part that attaches to his hearing aids. So whoever is wearing the Roger, when it's turned on, feeds directly into his ears. We have made a lot of choices about all of our kids simply because Kai has hearing loss. My kids are in premier soccer. I had no idea what that meant. But we decided to go with like, oh, we're going to pay a little bit more money for soccer because we don't want someone talking into his ears for 3 hours a week who has no idea what they're doing, right? So this affects every aspect of not just Kai's life, but our whole family. You know, Kai, he's a really funny kid. He really is. And he's never going to be fast at math facts. There are some kids with hearing loss that are really math smart. And Kai is. He's at grade level or above in all areas, but he is never going to be fast at math facts. Cries when he has to do it for homework, not because he can't do it, but because it takes him way longer than the typical hearing kid. Because in order to build a pathway for meaning, you have to hear that pathway verbally a certain amount of times, and he needs more repetition than a typical hearing peer. So, and this is not true for all hearing kids. Executive function can develop slower in different areas in different kids with hearing loss. That's just one example of Kai. And maybe it's because he's a lazy 9-year-old boy, but I can't separate that from his hearing loss. There was so much I didn't know in the beginning, and there's still so much I don't know, which is I'm passionate about newborn hearing screens, but I'm also passionate about talking to other families, which is why I'm part of Hands and Voices. So, several years ago in Colorado, a bunch of parents came together and formed a support group. Some used signs, some used spoken language, some used spoken language and C-sign, but they all came together with this commonality that their kids were deaf or hard of hearing. And from that group of parents stemmed an organization that is now international. It's called Hands and Voices, and it's just parents or professionals whose kids have hearing loss. And they just, they do fun events so that their kids don't feel isolated, right? So that they are in touch with other families and other kids who are like them to some degree. So Hands and Voices exists in almost every state. It's in Russia, I think it's in England, Australia, and almost every state has a guide by your side component. And the guide by your side piece is just parents like me who can be matched with a family whose child has been identified with hearing loss. And we provide emotional support. So instead of the FRC walking into my home and saying, okay, here are these 3 folders, pick one, I can say, you know what, I'd really like to talk to another mom first because I don't understand. And the FRCs, the people, you're busy, FRCs are busy, everybody's busy. And so as parents, we can slow down, take a minute, like the doctor was talking about, and explain in a non-biased manner, okay, here are your choices, what's going to be best for your family. Because no one should have told me, well, don't call that place, they're in transition, they're busy. I should have been given that option. So if you have a family that has a baby that's identified with hearing loss, you can give them this referral, or you can just fill it out. Because a lot of times, right, you tell a new mom, here, you want to talk to another mom? Fill this form out and send it in. That is never going to happen, right? Because you're a new mom and you're tired, and who really cares? So not that your baby's hearing loss isn't important, but it's just one more thing to do. And so oftentimes, if you fill this out for them and say, hey, this might help, how about you just talk to another mom? And that's all it is. It can be one conversation. It can be 10 conversations. It can be a lifelong friendship. I work a lot with families who are transitioning at age 3. They're leaving their early interventionist and they're scared. I also work with families when they turn 5 and they're entering their neighborhood elementary school or a private school. That's a huge, huge transition. And the older Kai gets, the more I learn it is all about the brain. So I can't just stick his hearing aids on, give the teacher a mic and say, have a good day, because it's so much more than that. It's teaching him advocacy. It's helping him. It's teaching him vocabulary that he's going to learn in school before he hears it. Because if he comes across a new word, not having ever seen it before, he's going to spend so much time trying to hear that word before he can move on. Everybody else has heard that word, and they're processing way faster than him. So it's so much bigger than just hearing aids or a cochlear implant or even just sign. I mean, it's all about the brain. So this is Kai now. This was in December. I'm sorry for the red eye. Our computer with the photos on it crashed, and so I couldn't go back and refix the pictures. So this is a typical appointment at a sound booth. The pink stuff in his ear, that's how they make the ear mold. So 9 years later, our trips to the audiologist are further apart. And then 2 years ago, we started to only go once a year. I cried when they told me that they didn't need to see me for a year. I was like, are you sure? I really think I should come back in 6 months. And they're like, this really isn't about you. And I'm like, no, really, it's about me. Kai's hearing loss has been really stable. It fluctuated due to fluid the first 2 years, but it's been really, really steady. So that just means that we only need to see the audiologist once a year, and we have to have new ear molds made. So that's what they're doing here. And then he goes into the sound booth, and they test his hearing with the hearing aids, without the hearing aids. This is obviously without the hearing aids. They just stick a little probe in. He hears sound. He does something fun in the booth. They make it really fun and creative. Recently, an adult with hearing loss told, I went to a conference, and she said, when I was younger, every time I stepped into the sound booth, I just thought, maybe if I try harder this time, I won't have hearing loss. Or maybe my hearing loss will get worse. And Kai has never expressed any of that anxiety, and I really don't want to ask him directly, do you have anxiety about the sound booth? But all that tells me is that the older he gets, the more I'm going to learn about how he perceives the typical hearing world and how he views himself in it. And part of that really scares me. But part of me, I know that they call this the invisible disability for a reason. I asked Kai, I said, hey, I'm going to go speak about newborn hearing screens and about having hearing loss. Is there anything that you want to tell people, good or bad? I had no idea what he was going to say. And he said, I think it's good to have hearing loss because it makes me unique and special. Which a couple weeks ago he told me, I really like having hearing loss because my ear molds make my ears warm when it's windy outside. So I was much more impressed by this quote. So he has had hearing aids since he was 6 months old. It's a part of who he is, and there have only been a handful of nights when he's really tired, and usually my husband is not there, and he'll say, I don't like having hearing loss, I don't want to have hearing aids, and we always validate his feelings. We're like, buddy, you're right, it sucks, but we love you, and we love how God made you, and we tell him that when he gets to heaven, he can throw his hearing aids in the trash. And we tell him, buddy, you hear things with your heart that other people can't hear. And I completely believe that with my whole being. The kid is all heart, but he works really hard every day. I'm not gonna cry. Every class, every meeting, every phone call, he can't call me from school when he's sick. Like the teacher, he either has to be in a closed room on speaker or the teacher has to communicate back and forth. And it's those little things, right? Video chats, movies, soccer, everything he does is impacted and different and harder because of his access to sound. But we totally embrace this journey, and sometimes we run a little slower, and sometimes we fight a little harder. But we look around, and the journey really is beautiful. He owns his hearing loss. He's amazing. He can explain it. He can advocate for himself. He picks out the color of his ear molds. Can you tell? Seahawks, actually any Seattle sports team. He remembers to take them out when he's swimming, when he showers. He brings the wireless mic to his soccer coach, to his baseball coach. His brothers really want hearing aids, and when Kai got his new pair when he was 6, Otto, his little brother, wore his hearing aids with the batteries in around for days. And basically, if you put it up to your ear, it goes, right, it kind of buzzes. He had that feedback for days in his ears. He just so badly wanted to be like his brother. My daughter's American Girl doll has hearing aids. It's his brother or sister who will spot another kid with hearing aids or cochlear implant in the park, and they will recklessly chase them into the parking lot. Wait, you have hearing loss. It's pretty awesome. Okay, so this probably won't work, but we'll give it a try. No. Really, I practiced this at home. I was so proud of myself. This is exactly what I wanted to show you.
5, 6, 7. Aha! You're on my apartment building on Granite Avenue. You owe me $300. Get it up?
Fred, take it easy. It's only a game.
Wilma, I'm just like them big tycoons. I play to win. Now, Barney, pay up or get out of the game.
One down and 2 to go. Baby, it's your turn. I don't have any more money either. You got it all. Then I'll take the mortgage on your open home. Come on, take the dice. Well, you don't just sit there like a dummy. I will not have you talking that way to I get. Come on, Barney. I think we better go home.
So you kind of get the picture, right? Okay, I don't know how to get back to the slide. Sorry. So I could stand here and seriously talk to you all day about the different hurdles that Kai faces or the way this impacts our life, but I'm going to tell you some funny stories. And sadly, the ones I remember are slightly inappropriate, so I hope you're not offended. So Kai was probably about 4. I have 3 boys, right? 3 boys. So you know what that means, right? Just kind of grossness all around. And he comes out of the bathroom and he's like, so what's that thing called when your butt burps? Fart. Who forgets? What 4-year-old boy cannot remember the word fart? And it's just, his brain just forgets words, right? Normal kid, that doesn't happen to typical hearing kids. He is at my in-laws and he's like, so what's that thing where I just went to get the popsicle? Freezer? Yeah, freezer. He spends a lot of time explaining the words he's looking for because his brain just, those pathways aren't strong enough and he just forgets. So my daughter, like I said, we've made a lot of decisions for our whole family based around Kai, and he was at this pre-K up in North Seattle. We live in South Seattle, and so it was like an hour commute one way. And my daughter was starting kindergarten, and I couldn't realistically get Kai way up there and Lucia way down here, so she went to Catholic school right next door to Kai's preschool for a year. And they did a lot of animal games at recess. So one school break, she's like, boys, I'm going to teach you this game we play at recess. And I'm making dinner, and the boys all march in with like markers or some kind of toy sticking out of their mouth, like a dog bone. And I said, what is happening here? And Kai said, oh, we're playing betch. And I said, wait, what? And he said, it's betch. And my daughter is in the bathroom and she goes, no, Mom, it's fetch. That's just what he calls it. And we just let him call it that. And I was like, no, come here. I'm like, that sounds like a bad word. So, I have to say, look at my mouth, fetch, and I say it in his ear, and things like that happen all the time. This is kind of inappropriate too. So we were in the fall. I had Lucia and Kai at Fred Meyer, and they made me push them in those ridiculous car carts. They're 9 and 10, and I'm pushing them in a car cart, but they were just so excited about it. So I'm like struggling to get through Fred Meyer, and they had this big display because it was probably around Thanksgiving. And Lucia goes, "Look at those crock pots." And I said, "Yeah, look at those. Those are so pretty. I might almost cook in one of those." And Kai said, "What? Crotch pot?" And we laughed. We're like, "Nobody, crock pot." He goes, "Yeah, I thought that sounded funny." And one time we were driving home from my in-laws and late one night, and they wanted music or a story, and my husband was like, "No, we're just going to be quiet, and we're going to keep the windows down and see if you can hear any sounds outside." And so it's really quiet for a few seconds, only seconds, and Kai says, "Oh yeah, I think I hear crickets." And the Chia goes, "No, dummy, that's the bike in the trunk." It was just like, yeah, it's just, he doesn't know what he doesn't know. He's not always sure of the sounds he hears. And you could say that for anybody, but it's really funny when it's Kai because he's so good-natured about it. And yeah, anyway, it's just fun. So I really believe, I really like to say that even though Kai is the one with hearing loss, we are a hearing loss family. And we have met some pretty amazing people, and I can't wait to see the things that Kai does with his life, but it would be really different if he never had a newborn hearing screen. Really, really different. So I only have a couple resources and links. One is for the National Hands and Voices website, one is for the Washington Hands and Voices website, and then the other one is for the EDDY program. If you Google EDDY with 2 Ds, you will pull up our state EDDY website, and it has tons of support, just pamphlets and stuff that you can give your families. I didn't want to give you a lot of paper because I figure you know what is going to work for your families. That's just a silly picture of Kai and a scarecrow. But for some reason, my email was cut off the bottom, but it's on the letter you received in your packet on blue paper. So I know this was a lot, and I hope that you walk away with a better understanding of why newborn hearing screens are important, the impact it can have on a family, and your role in the whole situation. And don't hesitate to email me or give my email to anybody. I am super available and open, and clearly I love to talk about my kids and hearing loss. So thank you so much for your time. Yeah, I think you're scheduled for a break again.
We decided that we kind of already had it when we were doing the setup, so we're just going to go right into the next speaker. Quickly, before that, I just want to remind people about Midwives with the Mic after the conference tonight. We have absolute karaoke coming, and we're going to have a really fun party. Even if you don't want to sing and you don't want to do karaoke, it's really fun to watch your friends do it. There's going to be wine and cheese and bread and fruit and conversation and fun. So if you haven't signed up yet, there is sign up at the back of the room where you registered and got your name tag this morning. And we're going to start just right after the conference, probably 5:30. So our next speaker is Dr. Helen Chu. Dr. Chu is an acting instructor in the Division of Allergy and Infectious Diseases in the Department of Medicine at the University of Washington. Her research is focused on maternal vaccines, in particular vaccines against influenza and RSV. Dr. Chu, sorry, I didn't highlight my whole thing here. She studies the virologic and immunologic correlates of protection from respiratory viral infections in mothers and infants in rural Nepal, and performs clinical trials of vaccine candidates in both domestic and international sites. Thank you very much. Please join me in welcoming Dr. Helen Chu.
Okay. So thank you to the organizers for inviting me to speak. I've actually lost my voice, so I've truncated my talk a little bit so you don't have to hear my hoarse voice for the next 30 minutes, and let's see how much I can get through. So I apologize if you have trouble understanding what I'm saying. So I'm a faculty member at the University of Washington. I study maternal vaccines, and I'm going to talk to you about how to prevent infections in mothers and infants, which is one of my favorite topics. So I'm going to go ahead and see if that works. Great. Okay. So first of all, I have some disclosures. So I received research funding from the Gates Foundation, from PATH, from the NIH, from GlaxoSmithKline, and the Centers for Disease Control for the research that I do in the US and in Bangladesh and Nepal. Some personal disclosures. I have 3 children. The baby in the middle was born at Northwest Hospital and was delivered by Michelle Grandy, who's one of the Northwest Hospital midwives. You guys might know her. And being an infectious disease doctor at work does not actually translate to heightened infection control practices at home, as you can see. So this is the outline of my talk. So I'm going to talk to you about a couple of things, and feel free to stop me at any point, ask questions if you have specific topics that you want me to cover, things that have come up in your practice that you would like to know more about. I'm happy to go off track. So I'm going to talk to you about how to manage 3 potential exposures during pregnancy: chickenpox, hepatitis B, and flu. And then I'm going to go over the currently recommended vaccines in pregnancy and the rationale behind them and when you give them, and the current research that's been published in the last 1 or 2 years going over the rationale behind these choices. And the vaccines that I'm going to talk about are flu and pertussis, so whooping cough. And the way I'm going to do this is in a case-based manner. So I'm going to go over the cases and then give you multiple choices and then have you just think in your head which one you would pick, and then I'll go over the answers and talk about the rationale. Okay, so this is the first case. So a pregnant nurse was exposed to varicella while taking care of a patient on the stem cell transplant unit. She didn't remember ever having chickenpox. The day her patient developed lesions, she called her midwife to ask if this was a problem. So what is the next step in management? A, nothing to do. We can assume that she's had chickenpox in the past. B, give the varicella vaccine. C, start varicella immunoglobulin, VZIG. Or D, send varicella IgG and wait for the results if less than 10 days after exposure. So why don't we do a show of hands? So anyone pick A, B, C, and D. Good, good, okay, exactly. So the answer that I would choose is D. And C is also appropriate if you're not going to be able to get an IgG. So the way that you would manage this, if you saw this patient, is the first thing you want to do is define the exposure. So varicella is very, very infectious. Before we started giving vaccines to people, to children, 9 of the 10 members of a household of a person with varicella would become infected with varicella, so a 90% attack rate, which is extremely high. So the criteria for getting prophylaxis with either a vaccine or with VZIG is sharing the same hospital room as a patient, having face-to-face contact with somebody with varicella for more than 5 minutes, or being a household contact. This nurse would qualify because they probably had face-to-face contact with their patient for more than 5 minutes. So the second step would be to see if the patient is immune. So women who self-report that they've had chickenpox in the past, you can assume that they are immune. 98% of them, when you check their blood, will have evidence of prior varicella infection. Those who say, oh, I don't know, maybe I did or maybe I didn't, I don't remember, my mom doesn't remember, 90% of those will have also already had varicella infection as well. But it's that 10% that you really want to capture. So if somebody says, I don't know if I've had chickenpox and I've been exposed and they meet these criteria, what you want to do is go ahead and send a varicella IgG, and we can do this at the University of Washington. You can get this back usually within 24 hours. Really, because you need to be able to start the prophylaxis within 10 days, After exposure, you want to send the varicella IgG if it's been less than 10 days. If it's been more than 10 days, it's questionable whether or not it's going to change what you do because they don't really technically qualify for prophylaxis anymore. So the next step would then to look at those results. So if your IgG is positive, you're done. You've already been exposed. You're immune. You're not going to get varicella. If your IgG is negative, you're going to give that person Varizig. And at this point, obviously, you'd probably be calling maybe an infectious disease consultant. But you would give varicella if the varicella IgG is negative and it's less than 10 days after exposure. Varizig is very difficult to get if you think you have a patient who has that exposure and you think you might need to give them Varizig. It takes about 24 hours to get it because there's only one place that makes it, and it's in Canada, and it takes some time to get it from Canada to the US, and it costs several $1,000s. So it's kind of a just a logistical disaster for us. And then the final reminder is that you never give a varicella vaccine in pregnancy. And the reason why is because it's a live vaccine and there's a theoretical risk that you'll transmit that infection to the baby. Any questions? Okay, I'm gonna move on. Okay, so second case, and this was, I think, requested by somebody who wanted me to talk a little bit about hepatitis B. So there is a patient from Eritrea on the Horn of Africa who comes to see you for her first prenatal visit. A routine hepatitis B surface antigen comes back positive. You send liver function tests, an E antigen, an anti-hepatitis B E antibody, and a hep B viral load. And her viral load is 2 million. So in this case, what is the most important risk factor for transmission to her fetus? A, vaginal delivery, you recommend C-section. B, breastfeeding, you recommend use of formula. Or C, high viral load, you recommend HBIG, hepatitis B immunoglobulin, and 3 vaccine doses to the infant. And you consider antiviral therapy for the mother. So A, C, good. Good. Great. So this is just a world map to remind everybody that even though we don't have much hepatitis B in the US anymore after routine infant vaccination, that in many parts of the world, especially parts of the world where many of our patients come from, like Ethiopia or Sudan or Eritrea, and Southeast Asia, especially at Harborview where I see patients, that lots of people still have hepatitis B. So a couple of points about hepatitis B. So we know that if you don't give prophylaxis, the perinatal transmission rate is 90%. And that most of that transmission happens as the baby passes through the birth canal, which makes you think that a C-section would prevent babies from getting hepatitis B, but that doesn't seem to be a protective factor. So vaginal delivery is fine in these babies. Birth dose of the vaccine that we're giving is really sort of like a post-exposure prophylaxis. So as you give the birth dose, you are preventing that baby from getting a potential infection from their passage through the birth canal. Breastfeeding and vaginal delivery are not contraindicated. And then when you have a hepatitis B surface antigen mother, you want to give them HBIG and 3 vaccine doses to the baby. And then this is not a recommendation, but based on most recent research, it sounds like 2 million is sort of the cutoff, that if a mom has a viral load that's that high, they're at incredibly high risk to transmit despite HBIG and the vaccine, that they have high rates of breakthrough transmission. And these moms, you would want to refer them to us, but then what we would do would be to give them antiviral therapy. So we have a couple of choices that are, and a lot of these are also used to treat HIV, so we know that they're pretty safe. So we would probably go ahead and start one of these 3 agents at 28 to 30 weeks of pregnancy. Okay, any questions about hepatitis B? Okay. So the next case. So there's a pregnant woman in her 3rd trimester who comes in February to see you. She has a high fever to 38.5, headaches and myalgias. Her fever has persisted for 5 days. You perform a rapid antigen test and this was negative. What's the most appropriate management? A, the antigen test is negative. She has a viral illness, but it's not flu. Nothing to do but rest in fluids. It's more than 48 hours since her symptoms started. She would not benefit from oseltamivir, Tamiflu. Nothing to do. C, she's pregnant, high risk for severe outcomes. Start oseltamivir. A, B, C? Yeah, C. That's right, C. She's pregnant and high risk. You would start oseltamivir. So, and the reason why is because pregnant women are very high risk to do poorly with their influenza. So some complications of flu infections. So influenza pneumonia, we know that pregnant women, especially in their third trimester who get flu, have a 23% risk of being put in the ICU if they're hospitalized. They're 5 times more likely to die from influenza than anyone else. Influenza can cause secondary bacterial infections. It used to be that back in the 1910s, there was a lot of streptococcal infections after flu, but now we're seeing a lot of community-acquired MRSA in the ICUs. Pregnant women can also get myositis. They can get encephalitis, and they can get inflammation of their heart muscle and associated MIs with that. So what antivirals would you use and when would you initiate treatment? So in most healthy people who come in with an influenza-like illness and you send an antigen test, the CDC says to not trust that antigen test. That if you think that they have flu and it's flu season, you just go ahead and start them on oseltamivir. Influenza antigen tests are not sensitive. If you have clinical suspicion, start the oseltamivir and don't stop if the antigen test is negative. And then in pregnant women, you would go ahead and start the oseltamivir even after 48 hours. The dose you would give is 75 milligrams BID times 5 days. We know that really the data for oseltamivir in healthy adults, the greatest benefit is the earlier you give it. But there was a study in Bangladesh last year which looked at giving oseltamivir up to 72 hours. And they found that in people who started oseltamivir at 72 hours versus 48 hours, there's really no difference in outcomes. So I think you can go out quite far. And I would say in pregnant women with symptoms, you just go ahead and start it no matter how long it's been, because oseltamivir is a very benign drug, and the risk of doing poorly with influenza is very high, especially if you get it in your third trimester. Questions?
Just statistics-wise, to be really simple about it, do you happen to know what is the absolute risk to a pregnant woman who has the flu versus like she's more at risk, but like
Yeah. Okay. So I think yes, I do. It's on the next slide. So and I'll go into that. But yes, they are more at risk, and I will show you those numbers. But I'll get to it in just a bit. So I'm going to go over some true or false for vaccines during pregnancy. So live flu vaccines cannot be administered to pregnant women. True or false? That's right. So there's a theoretical risk of transmission to the fetus with all live vaccines. Pregnant women should only receive inactivated vaccines. Influenza vaccine is contraindicated in patients with hives due to an egg allergy. True or false? False, that's right. So all flu vaccines are prepared with inoculation of virus into chicken eggs, Amish organic chicken eggs in Pennsylvania, and therefore contain ovoalbumin. But only patients who have true anaphylaxis are contraindicated from receiving the flu vaccine. Flu vaccine is linked to Guillain-Barré syndrome. True or false? It's debatable. I would say false, that the rates of GBS are actually not that different between people who receive flu vaccine versus not. And the risk of hospitalization with influenza is quite high if you do get it. So I wanted to sort of step back for a second and talk about vaccines and that you would give during pregnancy and how they actually work. So when we think about maternal vaccines and giving vaccines during pregnancy, we administer a vaccine to the mother in the third trimester. And the way that this works is that it stimulates the maternal immune response to produce IgG. This IgG level peaks in about 2 weeks, and then it's actively transported across the placenta, so that by the time the baby is born at full term at 40 weeks, baby actually has more antibody than mom has. So that it, and it's certainly true for things like tetanus and pertussis, and we're finding that to be the case now for RSV as well, that regardless of how malnourished the mom is, it seems like mom will efficiently transfer her antibody over to the baby, and then that baby will then go on to protect the baby, to be protected for about 6 months after birth. There's some thought that flu vaccine has an effect on birth outcome, that it can decrease prematurity or low birth weight. And there are a couple of trials that are ongoing right now in South Africa and in Mali and Nepal that are looking at this question. So what I like to think about when I think about maternal vaccines, and I'm obviously a proponent of them, is that when you vaccinate a mother, you are actually protecting the mother, the fetus, and the infant. And especially in parts of the world where I work, in rural Nepal or in South Africa or Bangladesh, a lot of women will not ever access healthcare until they're pregnant. That is their one chance. That is your one chance to really get to them. So when we give them a vaccine during pregnancy, like a tetanus shot, that's our chance to protect them and to protect the baby. So, and the next slide is going to answer your question. So this is the next case. So there's a 30-year-old female. She's G2P1. She comes to you for a routine visit at 32 weeks gestation. She got her tetanus booster during her last pregnancy 2 years ago, and it's currently October. What vaccines are currently recommended for her? A, influenza and Tdap. B, influenza, because she already got her Tdap within the last 5 years. Or C, none. Yeah, so that's changed. As of 2013, the ACIP now recommends that you get your Tdap with every pregnancy. So when do you immunize a pregnant woman? This is a slide courtesy of my colleague, Jan England. And I would say that it depends. It depends on what you're trying to protect, who you're trying to protect. If you're going to try to protect the baby, you're going to immunize in the 3rd trimester, because you're going to maximize your antibody titer and the transplacental transfer of antibody really 2 weeks after you give the vaccine. But if you're also trying to protect the mom like you do for flu, you really want to give it anytime during her pregnancy, during flu season. So what do we know about influenza and pregnancy? There's not a ton of data about seasonal influenza yet, but there is a lot of data about pandemic influenza. And we know that with pandemic influenza, pregnant women were at increased risk for hospitalization and death due to influenza compared to non-pregnant adults. So for example, 1%, so 5% of the deaths were due to H1N1 were in pregnant women, as to 1% of the general population. And that of the pregnant women who were hospitalized for influenza, 23% ended up in the ICU. And among the deaths in these pregnant women, 2/3 of these women were in their 3rd trimester. We don't have good population level data, if that's what you're asking for, about absolute incidence rates. So we know how many, based on Kaiser databases, but I don't know that we have them at the entire population. So the recommendation for pregnant women is to immunize them at any time during the flu season. This was a trial that was in the New England Journal this past year, where they did a randomized placebo-controlled trial of flu immunization in pregnant women and followed the moms and the babies up to 6 months postpartum. And this was in South Africa. When I'm showing you, they studied 2 groups, those with HIV and those without, and I'm showing you the HIV uninfected group. So this was the first study that has been done to look at whether or not giving a flu vaccine protects the mom or the baby from PCR or molecularly confirmed flu. Other studies have been done, but what they look at is symptoms, so flu-like illness, fever, cough, runny nose. But it could be due to any number of things, not just flu. What they found was that in both mothers and babies, giving a flu vaccine had a statistically significant effect on decreased rates of PCR-confirmed flu in both mothers and infants. So moving on to pertussis. So this is an epi curve of the pertussis outbreak in Washington State in 2012, which I'm sure many of you remember. We are again having a resurgence of pertussis in Washington state. These are some snapshots from the web that I found where looking at the pertussis outbreak at Roosevelt High School, as well as in several counties. Kitsap County, I think, is one of the major ones here in Washington state. And the question then is, why are we having an epidemic of pertussis in Washington state, in the United States, and also globally? So there are a couple of ways that we can think about this. So first thing is that the acellular vaccine, which is the one we currently give, that's the A in front of the P, is not as good as the previous whole cell vaccine, but it also has less side effects, and it also is less likely to blunt the infant response to vaccine, which is why we now do it in the US. We know that vaccine efficacy with pertussis wanes over time, that at 1 year it's 73%, but that at 2 to 4 years it's only 34%. And then we know there's a lot of vaccine refusal, and one sort of example of this was the measles outbreak at Disneyland. So, oops. What else do we know about pertussis? We know 30 to 40% of infants get pertussis from their mother, that the highest mortality of pertussis occurs under 6 months of age. 50% of, my brain, infants with pertussis under 1 year of age are hospitalized, not RSV. I just think about RSV all the time. So 23% get pneumonia, and then 1.6% die. But we can't give a vaccine to a baby until they're 2 months of age, because before that, the maternal antibody will interfere with the infant's ability to generate an immune response. So there's that critical window between 0 to 2 months that we really need to cover. So because of this, and because of the fact that your immunity doesn't last for more than a year, the ACIP now recommends that you give a Tdap during every pregnancy in the 3rd trimester. There are some concerns about this. You know, one of the things that's come up is that if you keep on giving somebody a vaccine over and over again, say they have 3 or 4 or 5 children, then is there some greater risk of adverse events? They haven't found that to be the case so far, and really most of the adverse events that we would see would be with the tetanus component, because that's the one that causes sort of the horrible thigh pain and the swelling and the fevers. And women in outside of the U.S., the WHO actually recommends that women get a tetanus shot with every pregnancy. And so we know that at least in that setting, in other parts of the world, that getting repeat tetanus shots is not a problem and does not cause increased risk of this kind of severe, it's called Arthur's reaction. Okay, so this is a study that just came out in the Lancet a couple of months ago, where in the UK, they've also been having a pertussis epidemic, and because of that, they now recommend that all moms get a Tdap in their 3rd trimester, and right after that, the US also changed their guidelines. And this is just a chart to show what happened after they introduced that guideline, that when they recommended that maternal pertussis vaccine was be given in the 3rd trimester, the cases of pertussis started to go down precipitously. So, so some take-home points. So we know that exposure to varicella during pregnancy is bad. You should check an IgG and consider Varizig. Hepatitis B transmission risk increases with high viral load. Oseltamivir can be started in a pregnant woman with flu-like symptoms at any time. No live vaccines during pregnancy, and that would include live flu, varicella, or MMR. Influenza vaccines given during pregnancy prevent flu in mothers and babies, at least in one trial in South Africa. Give the Tdap in the 3rd trimester, the flu vaccine anytime. And then call us with your questions. We're always available. This is our number. It's UW MedCon, and when you call us and you ask for infectious disease, you'll be able to get hold of one of us almost immediately and ask us your questions, and we're happy to help. So, thank you. Any questions? Yes.
Can you speak a little bit more to the concern about giving the tetanus part, like every year and a half, for instance, of people who are, pregnant not often, every pregnancy? That's not a concern?
That's not a concern. So the World Health Organization, because the goal is to eliminate neonatal tetanus, recommends that every woman who gets a tetanus shot during their pregnancy. So outside of the U.S., they get a TT, they get a tetanus toxoid, not the Tdap. So when they get that every pregnancy, and they usually have a lot of pregnancies, there hasn't been no problems. It does. Mhm. Oh, you mean could they just get the acellular pertussis portion? I think it's a matter of just how the vaccines are formulated in the U.S. The way that it's formulated is as a Tdap. But it's safe to get the tetanus part over and over again. Mhm.
Regarding the incidence of death,
Mhm.
was 1.6%. I understood on the slides. H1N1 was particularly violent.
Yes.
Is that the same number during other flu seasons?
We don't know yet, so I don't think so. I think that pandemic H1N1 was actually different. We're doing that study right now in Nepal, and we're not finding those numbers. But yeah, I don't know. I personally don't think it's going to be as bad with regular seasonal flu as it was with pandemic H1N1. So, yes.
And it sort of feels weird when it's not flu season. I mean, do you still recommend people get it?
No, you should only get it during flu season. Yeah. No, you should only get it during flu season, but you can get it any time in your pregnancy. So you don't just have to get it in your third trimester. Yeah. Yeah, the problem with, I always get asked, why is the flu vaccine not effective? Why does it only work 50% of the time? The problem is that a lot of the decisions about the flu vaccine are made about 7 months ahead of time because they first have to manufacture. It takes a long time to manufacture the flu vaccine because they have to grow it up in those eggs. And so a lot of decisions are made based on what's circulating in the southern hemisphere, which may not then be what's going to be circulating in the northern hemisphere the next season. It's just a matter of guessing. And so unfortunately, it's not always the best. Yes.
Going back to something that Dr. Danielson said about listening to people and meeting them where they're at, how do the different varieties of patients that you have respond to this? You have to do this section, this series of shots. You need to do this. Then you have to give this to your baby. How do different people react to that regimen?
So I am not an OB. I'm an infectious disease doctor. So I don't see pregnant women in that context, but I do talk to them a lot about other vaccines. And we don't usually, we don't present it. We try not to present it in a way that's, that is very absolute, the way I usually talk about it with my patients is I try to give them an example, do you know about what happened at Disneyland with measles? Measles can cause this. This is how a measles vaccine works. This is how effective it is. Why don't you think about it? So I know that there is a movement among pediatricians to stop accepting patients into their practice if they are not vaccinated. So I know that some people do it that way, but I think, obviously it's not going to work if you're very absolutist, and it's going to alienate people. And there are some patients who have very legitimate concerns. For example, my East African patients, they don't get flu vaccine because it has a porcine component, so they can't, for religious reasons, they can't get it. And we respect that, obviously. We just tell them, hand hygiene, wear masks, try to avoid sick people. So, yeah. Yeah, so the later you vaccinate, during pregnancy, the more likely you are to protect that baby during that vulnerable period. We know that the titers go down pretty quickly after your vaccine. So you'll get your vaccine 2 weeks later, you'll peak, and then you'll really just start dropping down. If you have to give a vaccine earlier, you're still going to have antibody at the time of birth. It's just not going to be as high as if you give it later. But I think ideally you would give it in the third trimester, but if you give it earlier, I think that's fine. It's still present, but it just isn't as high of a level. But I think any protective level is better than no protective level. So.
And if somebody's doing pre-conception care, they're doing their Tdap shot.
Yeah.
Giving it and then giving it again, or do you just?
I think just wait. Just wait.
It would be better to do it.
Yeah, it really is. There's very convincing data that looks at cord blood antibody in moms who get it earlier versus later, and those who get it later really have much higher antibody titers that they're passing to the baby. For whatever reason, the pertussis component just doesn't stimulate a robust, durable antibody response. You get it, and then it just goes away. Yeah. Mm-hmm.
If somebody were to get that vaccine in the third trimester late, would the antibodies be found in breast milk then?
Yes, they've done lots of studies to show that all sorts of antibodies are present. But yes, pertussis antibodies are there.
That's not good enough to give the baby some immunity for 2 months, or what does that look like?
Oh, okay. As in, like, if you give it after birth. So before we. Yeah. So if you give it, so it takes 2 weeks to peak. So you'll just be missing that 0 to 2 week period right after birth. So if you give it right, and then when they deliver, then for those first 2 weeks they won't get any protection, but after that they'll be protected. I mean, you won't transfer to the baby, obviously, but the mom will be protected, and the mom is often the source of infection to the baby. So there's lots of programs to try to vaccinate all the family members right after delivery. But if you're giving it really, really late in pregnancy, you're not going to get the antibody to the baby because it takes 2 weeks for that to peak. So if you give it at 40 weeks and the mom goes into labor at 41, baby won't have any antibody for mom. So, and it'll be in breast milk though, but IgA is short-lived, and because what you have in breast milk is not IgG, it's not a durable antibody response as the secretory IgA, so it protects them, but it's very, very short-lived. So it's just, I think it's fine, but really, if you want to get the antibody in the blood of the baby, then you really have to give it more than 2 weeks before delivery. Any other questions? Mm-hmm. Oh, I haven't thought of that question before. You're talking about hepatitis B. Okay. So if someone else in the household is Hep B surface antigen positive. Usually when we see patients who have a household member who's hepatitis B surface antigen positive, we recommend vaccination of all other household members. But if mom isn't vaccinated and then she delivers, and then whether or not to give that baby HBIG. So baby's risk of getting their hepatitis B generally comes from mom's birth canal. So yes, I would say that's true. Oh yes, absolutely. Everyone should be getting vaccinated. Yeah. Any other questions? So, as I said, this is our number. We're always available, and we're happy to answer any questions. Thank you for all of your work in delivering all of these wonderful babies. So.
That was so great. Thank you. I'd like to introduce Lauren Sacco. She's a doctor of nursing practice and neonatal nurse practitioner. Her capstone work, I'm going to have fun pronouncing this. Her capstone work was on hypoxic ischemic encephalopathy and therapeutic cooling, focusing on amplitude integrated encephalography and nursing education. She's currently working as a neonatal nurse practitioner in the Seattle Children's NNP PA group. Thank you. Please welcome Lauren.
Okay, can everybody hear me? Can you hear me now? Okay, good. So it's so nice to see all these babies here. I would have brought my 9-month-old if I would have known there was going to be all these babies. It's so great. So I'm really excited about this topic. I did, a bunch of work on it, so I'm overly excited. So I will try not to ramble about the topic, and feel free to ask questions throughout my presentation if you have any, and then we can talk at the end too. So let's talk about the patho of HIE. So it occurs in two phases. The first phase happens during the initial insult. So that would be any type of perinatal depression or depression right after the infant was born. So basically what happens is you have your sympathetic nervous system stimulation kick in. So blood is shunted from the vital, from all your other organs to your vital organs like your brain, heart, and lungs. You start with your anaerobic metabolism, but then as you deplete the stores, and you can imagine with tiny babies, they don't have a ton of stores available. So we quickly shift to anaerobic metabolism. You get depletion of ATP, cytotoxic edema, acidosis, cell death, accumulation of free radicals and fatty acids in the brain, and then leads to organ failure. The second phase occurs when the cerebral circulation and oxygenation are reestablished after resuscitation. And we're just now starting to realize in the last probably 10 to 15 years, we've gotten really good at our resuscitation after babies are born. So we're starting to see the ramifications of being able to resuscitate these babies who have had an initial insult. So that's where this therapeutic hypothermia has come in to play. There was a lot of research back in like the 40s and 50s based on drownings, cold water drownings, and being able to get those people and children functioning somewhat normally after those drownings because of the cooling that happens. So during the second phase, which is what cooling is actually hoping to avoid, we get brain injury that occurs as a result of the mitochondrial dysfunction. So you get increased calcium and free radicals and nitric oxide formation in the brain, and just keeps building and building and building. And the body doesn't have time to actually repair the injury that's occurred. So you get this huge injury to the brain and the body just can't repair it. And that's where you see the massive neurological effects of the ischemic insult. So here's a little diagram of kind of what happens. There's a lot of information up there, but basically you have your primary injury, which happens within the first minutes of the initial insult. And then you have this window where you have reperfusion to those organs who didn't have oxygenation during the insult. So that's the window that we're trying to capture these babies at. You have about 6 hours, and I'll talk about that a little bit later. But then if the babies end up getting into that secondary energy failure, you go to chronic brain injury. And there's all the cell death and apoptosis and necrosis. So the necrosis can actually be repaired. The apoptosis, which is actually the cell death, cannot be repaired. Am I going too fast? Just a little bit. Okay. All right. I'll slow down. So, okay. So I'm from the East Coast as well. So sorry about that. Okay. So what we're talking about today is the therapeutic hypothermia. So there's two different types. So there's total body cooling and there's selective head cooling. There are centers around Washington, and it's actually varied which centers provide what. Swedish Medical Center does head cooling. Valley Medical Center down in Renton does total body cooling. Children's does head cooling. So it just depends on what center they go to. So the actual mechanism of what cooling does is not totally unknown. Known. So we're trying to figure out as the research goes, but we do know that there's positive benefits from it. So what they think happens is that it reduces the metabolic demand that the brain has. So you get less cytotoxic accumulation, and it prevents that actual apoptosis from occurring. So it decreases the brain's glucose and oxygen metabolic rate. So everything actually slows down in the baby when they're cooled. You get loss of phosphates during the ischemic injury. You get decreased free radical production, decreased nitric oxide production, and it suppresses the inflammatory response. So you have about 6 hours to get the baby cooled. Sometimes, so there's a lot of criteria, and I'm going to talk about two different studies, which is the two studies that I actually have worked with. So I'm most familiar with those two studies. But there's a lot of things that the infant needs to meet before we can actually cool them. So that's why we have a window of 6 hours, and we're thankful that we do have that window, because sometimes in the first hour, the baby doesn't actually meet criteria for cooling. So there's a continued reassessment process that we do with these babies, hoping that by that 6 hours, they'll meet the criteria, so then they can be cooled. I have seen babies who, are like at 7 or 8 hours out, and then they meet criteria. And because these are still studies that are ongoing, we can't actually do cooling on them after that 6 hour window. There is research that's being done to see what happens if we cool these babies longer, but it hasn't been published, and the centers here in Washington aren't at that point yet. So hopefully in the next couple years, we'll know more information about that and be able to do something with these babies that present later on, but right now we don't. So total body cooling actually has demonstrated to maintain the core temperature better than head cooling. And so I've worked with that, and I've seen it work and not work as easily. I think it also goes with the experience of the providers that are providing it. It takes a long time to kind of figure out the equipment and how it all works, but I think that being able to cool regardless of what system you use is really beneficial for these infants. So the cooling system reduces the brain temperature to about 2 to 3 degrees below what it normally runs at. And so we have our core temperature set between 33 and 35 degrees Celsius. We cool for approximately 72 hours, and then we rewarm over a 12 to 24 hour period, depending on what study the institution is using. There are potential adverse effects just because we're slowing down the metabolic rate of the baby. Medications aren't as easily processed through the body, so if we're also concerned about infection, we get buildup in the kidney and liver. There's also, lack of perfusion to the gut, so then we worry about when we start to feed these babies what their guts are going to do. It also, I have seen babies that don't require intubation, so it slows down the process enough, but not enough to actually need intubation, but that can also affect them. So the two studies that I'm going to talk about today are the CoolCap and the National Institute of Child Health and Development. There are other studies called the TOBI, the Neo-Neuro Network, Neo-Neuro, so in Europe, that's that study, and then ICE is also done in Europe as well. So for the CoolCap, so this is the entry criteria, and it's pretty similar, but there are some points that are different. So for the CoolCap trial, you have to have a pH of 7.0 or a base deficit of greater than or equal to 16, or your APGAR score less than 5 at 10 minutes, or a need for resuscitation continued at 10 minutes. the moderate to severe clinical encephalopathy, and I'll show you how we assess that. And then they use the AEG, which is like an EEG, but it's just a 2-channel. So it's a little bit rudimentary as opposed to using an EEG. But what's nice about it is that you can set it up, the bedside nurse can set it up at the bedside. You get a lot of really great information off of it. So it shows brain function from one side of the communication of one side of the brain to the other. So that's what the CoolCap study uses. Also as part of their entry criteria for encephalopathy. The NICHD uses the pH of less than 7 or a base deficit greater than or equal to 16. But what's nice about the NICHD is that if you don't have a blood gas available, and the CoolCap really likes to have cord gases as what they base their entry criteria on, but sometimes it's not, we're not able to get those for whatever reason. So if we don't have that, we can look for through the history. So if we have this event and our APGARs are low and we need our resuscitation, then we can base it off of that. So we have a lot more criteria to use instead of it being very specific like the CoolCap is. So here's our SARNet score, and this is what they use to classify encephalopathy. So there's 6 categories. It goes through level of consciousness, spontaneous activity, posturing, tone, the primitive reflex like the suck and the Moro reflex, and then the autonomic system that I had talked about before, pupils, heart rate, and respirations. So there's a moderate encephalopathy and then there's a severe, and they just need to meet 3 categories to be able to meet the criteria for empathy. The research shows that if they meet the criteria in the moderate encephalopathy category, their prognosis is almost 80% better than the severe encephalopathy. Questions so far? Okay, so let's talk about some cases. These are actually cases that I cared for, so I know lots of information about it. So if you have any other questions, make sure you ask. So I'm going to talk about the labor, the delivery, the resuscitation process, a little bit of the admit information, and then their initial course in the NICU. So for baby I, 39 and 07's gestation mother presented with a spontaneous onset of labor at 9:30 in the morning. She had a history of an SAB and an ectopic pregnancy. So the fetal heart tones were normal until the following morning at 2:45 in the morning, where they became significant for prolonged late decelerations. And the mother also complained of severe abdominal pain, but the fluids were at that point clear. So concerning findings, the decels, abdominal pain, awesome. Okay, so a stat C-section was ordered. During the uterine rupture was noted. The NICU RN was there at the delivery who received a severely depressed baby. Okay, concerning? Okay, yes, I hope so. I'm concerned. Okay, so for the resuscitation, the infant was dried, positioned, and NRP was started with PPV. The nurse practitioner got to the bedside at approximately 3 minutes and 15 seconds of life. PPV continued, and we provided, this is pressures of 20/5 and with a decent rate, but baby was always on 21%, which is interesting. We did note spontaneous respirations at 4.5 minutes of life, but the baby was still floppy, poorly perfused, and still having significant respiratory distress. So we continued PPV and admitted to the NICU. So here's our admit information. We have our term baby at 39 and 0. Our APGARs were 1, 4, and 8. Our birth weight was 38.25. And here are our cord gases. So our pH was 6.86 with a base deficit of -14. And then our venous gas 6.9 with a base deficit of -15. So at our hour of life, our gas was 727 with a -7. So this just demonstrates the resuscitation process, and that within that hour we're able to get a significant improvement in our blood gas. So we're thankful for the NICU teams that help us. So we were intubated for respiratory support, and our neuro exam, so this is at 1 hour, was significant for extreme agitation and hypertonicity. Or sorry, that was at 15 minutes. And then at 1 hour, the baby was lethargic with decreased muscle tone and diminished primitive reflexes. So if we're going through our entry criteria, we have a depressed baby and PPV was given. Our cord gases and ABG were obtained at 1 hour, and they showed that the pH was below 7, so that was an entry criteria. We have our term baby with a good weight and less than 6 hours old, so there we go. So there's our pH. We didn't have any seizures, but we did have moderate to severe encephalopathy, so this baby was eligible for cooling. Do you want me to go back to the entry criteria? Are you guys okay? Okay. So baby W, it's our next baby. 37 and 3/7 gestation, received her initial prenatal care from the hospital midwifery group, and then transferred care to the community midwife for a home delivery. She presented to triage with decreased fetal movement, non-reassuring fetal heart tones, and a BPP of 4 out of 8. Parents were reluctant to sign the consent for C-section. So concerning findings, the BPP of 4 out of 8, decreased movement, then the non-reassuring fetal heart tones. Great. So this family came in at around 6 p.m. in that evening, and the C-section wasn't, the consent was not signed until around 6 a.m. the next morning. So there was a stat C-section ordered. Membranes were ruptured at delivery and fluids were clear. So the NICU RN and nurse practitioner were at the delivery, and they got a non-vigorous baby. Concerning? Yes. So initial NRP steps were taken place. Heart rate was 60, but PPV was started. We had intermittent respiratory effort, but the baby was still floppy. So it was intubated at 3 minutes of life. And at 5 minutes, we saw some gagging reflexes, so that's good. We want to see that. At 9 minutes, the baby was still intubated, was still getting PPV, and at 60%, and then admitted to the NICU. So some admit information on this baby. Term baby, 37 and 3. APGARs were 1, 4, and 6. So that qualifies per one of the criteria. We have a good birth weight. And here are our cord gases. So we have a pH of 6.95 with a base deficit of -18. So that's another criteria met. So 1 hour, our pH is good, 7.11, but our base deficit is still -18. So we're on the ventilator, but there's consistent spontaneous respirations over the ventilator at 1 hour of life. And our neuro exam at 1 hour is normal. So that basically goes, that talks about like the acidosis in the body and the body's ability to compensate for that. So we would like it to be 0. So it's by the blood gas. Yep. It's a component of the blood gas. Good question. So depressed baby at birth with PPV. Cord gases were obtained at 1 hour. We meet the criteria for gestation and weight. And then our pH was less than 7. We have our base deficit that was greater than 16. Seizures were not pregnant. Not pregnant. I'm not pregnant, I promise. No moderate to severe encephalopathy. So this baby wasn't eligible for cooling. So we do continue to assess this baby for the next 6 hours to make sure that they don't meet criteria later on based on their initial presentation. And this baby actually ended up doing really well. Went home after 4 days with no sequelae from initial birth. So it's positive. So here's the equipment that I've been talking about. So on the left-hand side is the cool cap machine. So you have your actual cooling device, which is the water flows through on a continual basis. Yeah. So that baby did have some neurological deficit at about 18 months, but was meeting the milestones at 18 months, but just had some a little bit of speech delay and some fine hand motor delay. So you're welcome. You're welcome. And I'll talk about some outcomes based on these two studies, so you'll get to see. So the on the bottom here is where the fluid flows on a continual basis, and then there's the cap that goes on top of that secures it, and then there's another cap that goes on top of that. So you can see this is kind of a tedious part of the equipment, especially because with the cool cap they use AEG monitoring, and those are actually really tiny needles that get inserted right underneath the skin of the scalp. So the cool cap has to be constantly taken off and placed back on. So that's why they have some issues keeping the core temperature stable, because they're constantly having to check and make sure that the sites are okay. And then right next to it is the machine, and it's from Natus. What's really nice about the whole body cooling is that the parents are actually able to hold the baby when they're being cooled. And that's one of my favorite parts about this, is that I think that especially in the NICU, we get really focused on the care of the baby, which is good, but I think we forget about the family unit. And I think that it's really important for these families, especially when, they're expecting to have a normal term baby and this happens, kind of rocks their world. And so if we're able to give them some sort of normalcy through this process, I think that we should do that. So it actually wraps around the baby's chest and then around the legs. You can change the diaper around it. You can do any kind of procedure. You can x-ray through it. And it's really easy to move the baby back and forth, whereas the cool cap, it's a little more tenuous to try to do things around it. Questions about the equipment? So they're fed by, they usually aren't fed in the first 3 days because, like I talked about earlier, the perfusion to the gut was compromised during the initial insult, and then we're cooling the baby so that metabolic rate and the actual gut motility is decreased. So we do, no breastfeeding or food for the first 3 days. So here's some outcomes from the study. So adverse outcomes are a severe delay at 18 months. Death is self-explanatory. Disability goes through the whole gamut of different types of disability. And then there's the severe neuromotor disability, CP, that kind of stuff. And then the MDI is the Bailey scoring. And then visual impairment. So if you look at the two based on so I have the cool cap information and then the NICHD information and then based on their controls. So you can see that it's not huge and the numbers aren't, oh my gosh, outstanding. But if you think about duration, this is a term baby that had an insult right at delivery or right before, otherwise would have probably had a normal course. We're saving, 33 or 73% of these babies if you look at death compared to 38 to 37. So it might only be 1 or 2 babies, but I think that's better than none. So I think it's promising. If we have the ability to do something for these babies, then I think we should do it. Okay, references. Questions? For 72 hours. Yeah, so once the baby's placed on either the cool cap or the total body cooling, they're maintained at that temperature for 72 hours, and then they're slowly rewarmed because usually at about 12 hours, well, not usually, sometimes at around 12 hours, they have this spike in their encephalopathic behavior. So it tends to look like they might be showing signs of seizures. So it can take up to 24 or 36 hours to rewarm these babies because we're reperfusing the injured area, so we don't want to do that too quickly to make sure that we're not causing more damage during that period. But it can't, so they don't cool any longer than 72 hours, and the longest rewarming has ever taken was 36 hours. So it's a fairly short treatment. And the babies that I've seen that have done well just had moderate encephalopathy, and they've actually, the majority of them do not have any like disability or neurodevelopmental poor outcomes at 18 months. So this is just at 18 months. I haven't been able to follow them farther than that, but just at 18 months. Yes. Yes.
Going back to the slide with the chart. And
This one?
yes, the controls. So like in that top adverse outcomes, the controls were 66% of kids who had no.
So 66% of the control group who did not receive cooling had adverse outcomes. And that's, so the top number is the cool cap and the bottom number is the NICHD. So in the cool cap, 55% of those that were cooled still had adverse outcomes. You're welcome. Yeah.
And then back to your two case studies.
Yes.
I was wondering in the first case.
Yes.
What was the precipitating factor to have this kid all of a sudden have T cells? And then in the second one, was there a cause of the poor NST and BPD?
So for this is the first baby, and so is this the first baby? Yes. So this baby, even though the fluids were clear, they were suspecting uterine rupture. That's what precipitated this baby having the prolonged late decelerations. Okay, and then for the next case. Give me a second. Now I'm trying to remember. They were actually unsure about what was the cause of this baby's depression. Mm-hmm.
Mm-hmm. This is based on a case that actually was in my neck of the woods that was transferred to the U. Where is the cutoff? Well, okay, so what happened is that she had placental abruption secondary to preeclampsia.
Okay.
She wasn't in my care at the time, and it was really urgent. They lived 45 minutes from the hospital. I mean, she lost liters of blood. The baby was unresponsive. They worked on for 20 minutes to resuscitate in the Tri-Cities, and then flew him to the U where they started a cooling process. At what point do you stop?
Oh, that's a good question. I think that's the question we all ask.
I mean, he's the last thanks to machines currently. I mean, and that's it.
Sure. So a lot of times the practitioners or providers, if there's a treatment modality that we can provide that's shown such great benefit for these babies, then they'll provide it. And so we have that 72 hours to see if it will work. And then after that, I think it's a very delicate discussion between the providers and the family on outcomes and stuff. And the data is really great, and there's a lot of data that supports kind of the follow-up to 18 months after cooling and what kind of outcomes these babies do have if they're showing these that type of presentation after cooling, if they're still on the ventilator, still on support, still requiring feedings by a tube, and then they get an MRI and the EEG and the neurologist get involved. The data shows that the outcomes aren't very good. So I think it's a parent's choice. I think, and I can't speak to the U or to what they do there, but I know that the option is always talked about as far as withdrawal of support and that kind of stuff. So. Any other questions? Thank you. Thanks for letting me come and talk. Just take the plug in.
Wasn't that an amazing day? Yeah. I'm so glad that the community asked for a high emphasis on clinical topics, because I just felt like that was a really fantastic way to spend a day. Very informative. I don't know if Valerie might have some things to say also, but I just want to thank everybody for coming. I know a lot of work went into this conference. We had a committee of people all pitching in and doing different parts. So it was very much a group effort. So I just want to honor the efforts of everyone on the committee and everyone who's come and participated. Okay. Thank you. And I guess the last thing I'll say is please come to the party. It's being set up right now. Josh is here. It's going to be a ton of fun. We actually need to wait until he is set up and has his cords taped to the floor, so that it's a safety issue. But if people need to hang out in the lobby before going into the room, we will distribute wine and everyone will be happy. So please come. Oh, Val has nothing to add. I don't know. Okay. Thank you. Don't forget to turn in your evaluation back of the room so you get your CEUs.